Yeah, like please.
Very good morning, everyone, and welcome to the AIOS GuruSangam session 19 for oculoplasty. It's a wonderful opportunity to begin the year with an oculoplasty session. A very happy new year to everyone. So, I would like to first thank our AIOS dignitaries, Dr. Partha Biswas, President AIOS, Dr. Santosh Honawar, Honorary General Secretary of AIOS, Dr. Manoj Mathur, Sir, Honorary Treasurer. The speakers for today's session are Dr. Shubha Zawar, currently associated with Government Medical College, Jalgaon, and Dr. Aparna Pillai, Maharaja Agrasen Medical College, Agroha, Dr. Sonam Nisar at Shankara Nethralaya, Chennai, Dr. Swati Sri Nayak at AIMS, Guwahati, Dr. Arvind Kumar Maurya at AIMS, Bibinagar. The expert panel for today's session are none other than Dr. Senthil Nathan from Ramanna Eye Center, Chennai, Dr. Dayakar Yadalla from Arvind Eye Hospital, Pondicherry, Dr. Kirti Koka, Shankara Nethralaya, Chennai, and Dr. Seema Das from Shroff Charity Eye Hospital, New Delhi. Today's topics that we're going to cover is going to be contracted socket, its evaluation and management, covered by Dr. Shubha Zawar, applied embryology and anatomy of the orbit by Dr. Aparna Singhal, approach to a case of proptosis by Dr. Sonam Nisar, orbital tumors by Dr. Swati Sri Nayak, medico-legal aspects in human and drug trials in India by Dr. Arvind Maurya. Moderating this session with me today is Dr. Shebin Salim from Giridhar Eye Hospital, Kochi. Thank you so much, everyone. We will move to the first speaker, Dr. Shubha Zawar. She will be talking to us about contracted socket, its evaluation and management. Over to you, doctor.
And this is Ananya Abhayankar from Joshi Hospital, Gwalior.
Right.
Just a moment.
Sure.
So yeah, so is my screen visible?
Yes, absolutely, ma'am.
Yeah,
Visible
so-
and clearly audible.
Yeah, so at the outset, I would like to thank the AIOS chair, Dr. Partha, Dr. Santosh, and Dr. Mathur for inviting me here for this wonderful initiative, GuruSangam. And I'm Dr. Shubha from Professor of Ophthalmology at GMC Jalgaon. So I'll be sharing my talk on contracted socket evaluation and management. I have no financial interest, and some content has been used from online sources strictly for academic purposes. Now, this patient wants a cosmetically better appearance. So, what problem does she have, and how can we help her? That is what we are going to learn in this session today. So, we will learn about the etiology, the evaluation part, and the presentation part, and describe the management which will be available. Now, what is a contracted socket? Now, this, as you can see, is it's the normal orbit that you see here. And then if the orbital tissues shrink or there is a reduced orbital volume, this will result in a decreased fornical depth. All this happens if the eye is going thigh-sick, or there is an anophthalmos because of enucleation or evisceration or some trauma happening there. So shrinkage of orbital tissue accompanied by reduction of the orbital volume along with a reduction in fornical depth is what causes a contracted socket. Now, this might be a soft tissue or a bony contraction, and this will, of course, result in inability to retain a prosthesis or an artificial eye shell, and which is very cosmetically unacceptable, and the patient has a significant functional and psychological disability, and we are here to help him improve the quality of life, and that's why we need to study this. So what could be an ideal socket? So I want to just a moment. So I just want to to line out what is an ideal socket. So it should be lined with a healthy conjunctival epithelium, and there should be a centrally placed implant with an adequate volume and adequately deep with an adequately deep inferior and superior fornices for the prosthesis to retain, and optimal motility of the prosthesis is also very important. and position should have eyelids should be very well positioned, and then a well-fitted prosthesis should be there that looks very similar to the contralateral eye. So that is what we are looking at to achieve an ideal socket. Now, about the etiology of contracted socket, like why does it happen at all? So the causes could be congenital, like congenital enophthalmos or cystic ocular remnants, or microphthalmos, and acquired cases like surgery related or implant or prosthesis related and etiology related causes might be there, which result in a contracted socket. So why the slides are not moving? Yeah. So as I told you, trauma and surgery related is where poor surgical techniques, of course, it sometimes becomes iatrogenic. That is because of our bad, poor evisceration or enucleation that we do, poor surgical techniques resulting in a contracted socket, or there is fibrosis after initial trauma, or multiple socket procedures have been done resulting in this contracted socket, or ocular surface related, could be because of cicatrizing disease of the conjunctiva, or maybe some socket infection or inflammation, or a keloid formation and poor vascular supply of this. So this all will result in a contracted socket. Now, prosthesis and implant related is where, because of non-wearing of the prosthesis, or a faulty or ill-fitting prosthesis, if the patient is not regularly wearing, or he has not exchanged the prosthesis, or because of implant migration or exposure. And it might also be due to other reasons, like an irradiated socket after enucleation because of malignancy, or an alkali burns. Now, epidemiologically, an ophthalmic socket is rarely congenital, only 0.2 to 0.3 per 10,000 live births. But an acquired anophthalmia is 2.6 to 5 per 1 lakh population is seen. The history and presentation. Now, how are we looking at, like when the patient presents to you, how are we going to evaluate or ask history? So the patient always presents with inability to sustain a prosthesis, or he might be having some discharge due to poor prosthetic fit, or the artificial implant, or it may be associated with poor movement of ocular prosthesis and poor appearance and some lid abnormalities as well. Now, for the history and examination, history of prior surgical procedures needs to be asked. So why that procedure was done, like why enucleation or evisceration was done, whether there was a malignancy, or there was a history of trauma, or some congenital malformation. When was it done? Like, was it done secondarily? So you should know whether an onset of fibrosis was there, then the type of implant which was placed, and whether there was any complication thereafter. And thereafter, we go on to the detailed clinical evaluation, and imaging can be done to further evaluate the case. Now, just give me a minute. I need this. Highlighter to stop. Yeah, so evaluation is important here, wherein you must go for evaluate the contracted socket, then evaluate the prosthesis, and then compare the appearance and symmetry with the fellow side. So that's really important, right? So now this lady comes to you. So we are evaluating the patient with the prosthesis. You can see a very deep or a sunken superior sulcus over here. Now this was a lady of orbit choroidal melanoma, for which she was enucleated, and the socket was irradiated. That's why she has a very contracted socket here. Now here in this case, this boy, you can see that the the implant is a bit large and a large prosthesis is there. That's why you can see the scleral show. Here, this was a case of a trauma where there is a mild ptosis there and the lid is deformed. Now, the symmetry in the both eyes is quite good, and he looks good. He was happy with the prosthesis that was implanted. Okay. So now next we go on to the palpation part, where presence and position of the implant uh, so presence and position of the implant is seen. So an inferiorly displaced implant can often obliterate the fornix. Then excessive eyelid or canthal tendon laxity also needs to be addressed for the prosthesis to maintain there. And extraocular movements and tone of orbicularis is seen. And of course, CT scan should be done to assess orbital cavity size. It could be hypoplastic in congenital anophthalmos, or there could be bony contracture and associated orbital fractures. And the presence and size and position of an orbital implant can be seen. So likewise, you can see that there is an displaced implant is seen here, and this is a case of post-enucleation socket syndrome, where you can see visualize the implant very well on CT scan. Now, evaluation, thereafter you remove the prosthesis and then evaluate the socket without prosthesis. Now, here you have to check for the surface as such, like how it is, whether fibrous bands or symblepharon are there, and it should be assessed for depth of fornicis, loss of volume, vascularity, or any inflammation. So on surface area, now we are going to see all the surface of the socket. How is it? So here you can see that there is multiple granulomas are seen here in the socket. This is a grossly inflamed socket. And this one, there is a superior sulcus deficient hai, and a lot of vascularity is seen in this. Here you can see in this case a lot of fibrous bands are there, symblepharon is there. This was a old case of trauma with a deformed facial symmetry. Now here we are now going to evaluate this lady. Now she's not happy with her face. You can see the goggle over her. So she hides her eyes because the left socket is really contracted. You can see the deficient, there is a inferior fornix as well. So the surface area is really deficient. And the upper fornix is also deficient. All the fornices are deficient. And you can see a rudimentary eyeball inside here, right? So next we go on to the volume assessment, where superior sulcus deformity is seen, which is a sign of volume loss. Then the depth has to be seen to check for a shallow or shortened inferior fornix. Also, it will lead to a poor fitting of the prosthesis. Here you can see there is a gross superior sulcus deformity here. So it is seen. So there is a volume loss over here. Now here there is a inferior scleral show that shows that the lower lid is lax. And so this is what we need to assess while evaluating with the prosthesis. Then you must also evaluate moist versus dry socket. So moist is where the mucosa is healthy and it is clean, and dry where the mucosa is smelling, foul smelling and keratinized and the surface appears dry. Now, there is a grading given for this contracted socket, and so most widely used is the Gopal Krishna classification, which is very easy to remember. It is divided into grades 0 to 5, where grade 0 is a healthy socket with deep and well-formed fornices. Grade 1 is only one inferior fornix is shallow. Grade 2 is loss of superior as well as the inferior fornix. So 2 fornices are lost. Grade 3 is where there is an involvement of all 4 fornices, superior, inferior, lateral, and medial. And grade 4 is where the involvement of all 4 fornices, along with a reduction in a horizontal palpebral fissure length, that is phimosis, is there. And grade 5 is where recurrence of contraction after repeated correction attempts. So the socket is presenting here. So here you can see that all the 4 fornices are deficient, as well as there is a horizontal palpebral fissure deficiency, which results in so this is a grade 4 contracted socket. So another classification is clinical classification, where mild is only one fornix, usually inferior is shortened. Moderate is where both superior and inferior are involved, and there is a decrease in area. And severe contracted socket is where all four fornices are involved and phimosis is there, so there is loss of area and volume as well. And malignant is where severe loss of area and volume plus there is a bony contracture. Now, prevention is most important as far as we are concerned. We as ophthalmologists should prevent happening the socket going into a contraction. So, a meticulous primary procedure like an evisceration or enucleation for optimal functional and cosmetic outcomes need to be done. You must preserve the conjunctiva antennae while dissecting and insert an adequate sized implant at the proper time and perform a layered closure over the implant. Use of customized prosthesis is very important post-op, and a regular follow-up is must. So this young girl, an adolescent girl, comes to me with an anterior staphyloma of the left eye, and there she wants a cosmesis here, a good appearance. So we went ahead with an evisceration and implantation of implant. So now evisceration of 4-petal technique is more important here, so that with all the flaps comes the muscle, and also dissect the optic nerve so that you implant a proper size prosthesis inside, cover it with the flaps, so these flaps overlap each other with the muscles. So the implant then remains in place. There is no any extrusion or something like that. And then a conformer is placed, a tarsorrhaphy is done, and that is how smiling she was with a good prosthesis. So a good prosthesis is a well-fitted prosthesis. It maintains a healthy socket. It is not irritating the socket all the time, causing inflammation and discharge. And this increases the patient comfort and, of course, creates a balanced facial appearance. Now, two types of ocular prosthesis we get: ready-made artificial eyes and customized prosthesis. So customized prosthesis, of course, gives a better fit and aesthetics, and it matches the other eye very well. So that is what is advised. Now, orbital implants, following enucleation and evisceration, we are using these to replace the volume loss. And there are two types, that is integrated med-pore implants you get, or nowadays very easily available non-integrated silicone PMMA implants are got. And implant size is important for optimal volume replacement. Now, this can be found out by the A-scan of fellow eye. So deduct 2 millimeters from this implant diameter, and you get the size of the implant that needs to be put. Usually 20 to 22 millimeters is sufficient. Now, treatment, going on to the management part of the contracted socket. The major goals here are, of course, to create a healthy socket which holds a stable prosthesis. Then attainment of orbit and eyelid symmetry is must. Optimization of motility, of course, so that the samne wala person doesn't know that you're wearing an artificial eye shell, and that is important for cosmesis. And this will mainly depend on the severity of the contraction and residual orbital volume. Now, acquired contracted socket management we are going to look at. Now, if there is an inadequate surface, then we can use phonics forming sutures, or you can use mucous membrane graft or an amniotic membrane graft, or even if required, split skin graft. And of course, with lid laxity issues, so you can use tarsal strip procedure, or likewise to address the lid abnormality. Then if there is an inadequate volume, we need to replace it with an intraconal implant, or you can use a dermis fat graft. If there is a combined surface and volume deficiency, then you can use dermis fat graft, as well as either a temporalis muscle graft or a radial forearm flap as well. Now, for a mild contracted socket or grade 2, where there is just a shallowing of inferior fornix, it can be effectively managed by fornix forming sutures. You deepen the fornix either by a closed method or by an open dissection. And thereafter, you have to put a customized prosthesis. And you can also address the lid issues. So this is how a fornix forming suture is taken, with shortening of the fornix, which is usually inferior. So a closed method is where the fornix forming sutures are taken, and these are passed through the conjunctival fornix deep down, and then they are externalized and sutured over bolsters. And also you may do a lateral tendon tightening, and put a prosthesis for an optimal position. With fat prolapse, if it is there, then, or some other fibrosis bands or so, then you can open method of fornix repair is done, where fornix reconstruction, complete release of fibrosis by dissection under the conjunctiva to the orbital rim, horizontal tightening is done, and then you may place a buccal mucous membrane graft to form the fornices. Now, in a moderately contracted socket, that is shortening of all the fornices, now you have to place a mucous membrane graft. That is the gold standard. The preferred donor site is lips, and you may also use it from the cheek depending upon the size, whatever you require. So harvesting of buccal mucous membrane graft is done from inside the lower lip, and some mucosal tissue is trimmed. It is dissection is performed, the conjunctival fibrosis is dissected out, and the mucous membrane is sutured to the host bed. And here you can see that an adequate surface and a fornix depth is formed. Then a severe grade 4 to 5 contracted socket. So here there is a characteristic volume as well as surface loss. So if the volume loss is more than 50%, then prosthesis alone is not sufficient. You have to go for a secondary orbital implant or dermis fat graft. So a dermis fat graft is an autologous implant, readily available, inexpensive, and it is indicated in a severe contracted socket for volume and surface loss as well. So donor site is gluteal region, and avoiding the important structures here. So this is how the dissection is done, a dermis fat graft, and graft size is usually more. A banana shaped graft is taken, and the epidermis is denuded from it, and the dermis with the fat going deep, we remove that graft, and then it is placed after the conjunctival dissection is done, and a conformer is to be placed. Fornix forming sutures are taken. That is how it helps increasing the volume of the contracted socket. Now, various complications are seen. So atrophy might occur, or pressure necrosis might be seen in dermis fat graft. Now, for grade 5 contracted socket, which is a malignant or inoperable socket, they say that these are all recalcitrant sockets, and exentration followed by fitting. Customized osseointegrated facial prosthesis may be done for such procedures. Now, for a dry and grossly contracted socket like so, you can use split thickness skin grafting, which is harvested either from the thigh. So that can be used. So this is a post-enucleation socket syndrome. This was termed by Tyler and Colleen, and this is characterized specifically by a superior sulcus deformity here, and so here, and laxity of the lower lid is there, and lid anomalies like ptosis or retraction, and a very ill-fitted prosthesis. So here you have to replace this silicone implant, and then use it for reconstructing it. Now, various complications are seen, like a flap or graft-related complications like necrosis and atrophy, like I talked, or hematoma or granuloma formation, or implant-related complications like exposure of the implant, extrusion, or infection, or an improper size is used. Therefore, patient education becomes a very crucial part here. So patient counseling is most important after whatever surgery that you do. So this is to avoid the disastrous complications and more contraction forming. So frequent follow-up is important. You have to address their hygiene and self-care, address that is important, and use of customized prosthesis, a thorough cleaning, and periodic replacement. So this is a lifelong follow-up with you, and that you must do to enhance the cosmetic and functional outcomes. Now, congenital contracted socket is a difficult ball game. So it might happen in both anophthalmos or microphthalmos. Shortening of the eyelids is there, leading to phimosis, and also bony hypoplasia is there here, and facial asymmetry is there. That's why an early intervention is what is required. So steps here is first to expand the horizontal and vertical eyelid apertures, then recreation of fornices, and then the expansion of bony orbit and replacement of volumes. So for in expansion of the eyelid apertures, you use serial conformers. Expanding hydrogel conformers can be used, and these can be fully hydrated, and they expand and can be replaced with larger expanding conformers. So dumbbell shaped or champagne glass or custom scleral shells are available. And for orbital expansion, then you have balloon expanders, dermis fat grafts, or hydrogel expanders and integrated orbital tissue expanders. So these are expandable hydrogel socket implants that can be implanted, and these can be used for the orbital expanding the orbital things. Now, or for orbital implants, then balloon expanders can also be used, where this balloon can be inflated with saline, and it predicts a predictable orbital and soft tissue growth. There are various hydrogel expanders as well, and these can be used, and these are self-inflating without injection ports, so have less complications. Then you have integrated orbital tissue expanders, which are anchored to the lateral orbital wall. It is and therefore these are supposed to be safe and effective, and these can be expanded and inflated and deflated as needed. And then for the small bony sockets, of course, you can go for 3D osteotomies. C and U-shaped osteotomies can be done to increase the orbit, the bony orbit, as well as bone grafts can be used. So this is how it can be done. And I had a few MCQs, so you can follow these, read, and attempt after learning this topic. So thank you so much. Thank you, AIOC, and thank you, organizers. I think I am in time.
Thank you, ma'am. That was a very nice talk, very well explained. So I remember as a postgraduate how difficult it was to evaluate, case of a contracted socket or a socket access, because there are so many things. The lids are there, could be associated entropion, ectropion, ptosis, the socket. So it will be like very difficult. So very well covered. So let us see the opinion from our panelist. Dr. Dayaga, sir, any comments from your side?
Excellent talk by Dr. Shubha madam. She covered all the topics from the etiology, classification, the management, and then the recent advances like expansion, all that she covered. As a postgraduate, always remember, try to remove the processes and then see what is there behind. Most of the postgraduates, they skip that step because it is like a discharge will be there. So remove the processes and see what is there any healthy socket, or is a discharge is there? Is there a granulation tissue is there? If it is a granulation tissue is mainly due to the irritation of the processes. There is a sharp edge, change of processes or a polishing is the process is important. Then the second point is always examine the other eye. As madam mentioned before, there might be a malignancy like a retinoblastoma or a melanoma. So you need to examine the dilated fundus examination of the other eye is very, very important. Sometimes we might miss a glaucoma which is a irreversible condition, and diabetic retinopathy. So then there is a recurrent malignant contracted socket. So in that cases, we can go for a superficial temporalis transfer. It's a superficial pedicle graft sort of thing. So it can do little bit cosmetically better outcomes. Then that she covered very well. Thank you.
Any other comments from the expert panel?
Yeah, Dr. Shabin, good morning. Dr. Sanil here.
Yeah, good morning, sir.
Yeah, congratulations, Shubha madam. Excellent talk. You presently covered almost everything. I think one important point is the PG should understand. Sometimes some ophthalmologists advise the patients to take off the shell when they're sleeping, which should not be done at all, because that is one of the most important reasons for a contracted socket. The socket needs to be continuously stretched, has to be kept under stretch. So it's not like a contact lens where you take off the shell at night and then put it back in the morning, because once you do that, especially the early stage, suppose it's anophthalmia or something, you want to expand the socket, the shell has to be continuously placed in the socket so that it is at a stretch. Now that's a very important point. And also how to deal with the exposure of the implant is an important question. Exposure of orbital implant. which is not uncommon once you do a surgery and place orbital implant. Exposure, it comes, how do you deal with that? What are the techniques which it's a vast topic which I think will be covered in the coming days. But it's a very excellent talk, covered complete 360 degrees. Thank you, madam. Thank you.
Thank you. Thank you, sir.
Just one question on behalf of pages from my side. This is very simple, but it's confusing that when it is associated with the ptosis, it could be pseudotosis or ptosis. So how to go about in such a case?
So basically, the reason of the ptosis is a small prosthesis and or a migration of the orbital implant or a small implant. So that should be addressed first. Then only the patient, the ptosis will be addressed. Okay. So there is ideally, if you place a proper size implant and well placed this. Small implant is taken care of, then the ptosis will not be that much. And the patient will be happy like. So that is the thing. And also customized prosthesis can be used. So a thicker prosthesis can be used for to address this ptosis, right? That is what I feel.
Yes. Yeah, thank you, ma'am. Good morning, Dr. Kirti.
Really lovely talk. You covered everything. I just wanted to add a small thing for the postgraduates. In cases like an adult who already has a ball implant in situ, but still there is a post-enucleation socket syndrome a little bit with volume deficiency. Another thing that can be considered is autologous fat graft injections. We can harvest autologous fat graft and inject it retrobulbar to push the implant forward, which will correct the volume deficiency. Another option is even fillers, which are readily available for cosmetic purposes. They can also be used for volume augmentation. Even in congenital cases, you can use it for expanding the bony socket. Fillers can be used or autologous fat graft can be used, and you can expand the socket with these. And then we correct it. Sometimes, how much ever we correct, there will be some amount of ptosis residual. These cases can be managed with an LPS surgery. For the question that you had asked. Yeah.
Okay, thank you. Any comments from Dr. Seema Das? Ma'am, you are there.
Yeah, I think a very excellent and very comprehensive talk, Dr. Shubhan covered it really well. I just wanted to emphasize one point, since we are talking about contracted socket, and maybe the postgraduates who are listening to it. So the prevention part of contracted socket is equally important as managing it. And I think as a postgraduate resident, most of the time, evisceration and other surgeries are the ones which are usually done by them at the end of the day. So while doing the primary surgery, taking care of the conjunctiva, ensuring that we put an adequate size implant, all those things are going to ensure that we don't land up with a contracted socket. So that's something we should also be careful about.
Yeah.
Okay, thank you, ma'am. Thanks again to Dr. Shubha Jawar. So if no other comments, let's go to the next topic, that is medical legal aspects in human and drugs clinical trials in India by Dr. Arvind Kumar. Over to you, sir.
Is my screen visible?
Yes, sir.
So, a very warm good morning, esteemed chairpersons, Dr. Dayakar, Dr. Senthil, Dr. Seema, and Dr. Kirti. And a special thanks to our today's host, Dr. Shabin, as well as Dr. Ananya. And at the outset, I would like to thank our President, Dr. Harbans Lal, and the AIOS General Secretary, Dr. Santosh Ji Honawar, for initiating this wonderful program, GuruSangam. And it is going on, I think it is continuously for the third year. And special thanks for accommodating a perfect anomaly among the grades of the oculoplasty surgeons. So I will be speaking on medico-legal aspects associated with research involving human and drug trials in India. So first of all, I would like to dedicate my talk to Dr. Shambhunath Dey, who deducted that the cholera is caused by an exotoxin. And Dr. Dilip Mahalambis, and he was a pioneer in making a mixture of the salt, sugar, and water, that is the ORS, and that reduces the fatality rate from more than 90% to only 4% in the cholera patient. So why is the need of the medico-legal factors in research involving the human trial? So during the Nazis regime, more than 15,764 officially documented victims died, but the true figure was in millions. And the method of Jew massacre in the name of experimentation and research was there. And one of the incidents, mass sterilization of more than 3.5 million Jews. And in this picture, you can see a Jewish prisoner in a spatial chamber is responding to how the breathing and the oxygen concentration will be there during the high altitude experiments at the height of 15,000 meters. So this is the importance of the Nuremberg Code that was on the 28th of August 1947, and this was a path-breaking foundation stone for the human drugs and clinical trials. So it derived from a German Nuremberg Codex, that is a set of ethical research principles. So there was this human experimentation created by the court in US versus the Brandt and subsequent Nuremberg trials that were held after the Second World War. And code would later become significant beyond its original context. And in a written review on the 50th anniversary of the Brandt verdict, J. Kretz specifically writes that this reading of the judgment suggests that the authors wrote the code for the practices for the experimentation whenever it is being conducted in the research as well as the human clinical trial. Then came the importance of the UNESCO and the World Health Organization, and these are both the international bodies played an important role in perfecting the SOPs for the human research and clinical trial. So there is this UNESCO's Universal Declaration on Bioethics and Human Rights that came in 2005. And WHO established International Clinical Trial Registry Platform. That is a one-stop. So there is a universal ID for any multicentric and multinational clinical trial. And then we all know that International Committee of Medical Journal Editor, ICMJ, is there. So mandatory registration is there. And in all our publication, we must follow this ICMJ SOPs. And in India, the ICMR and CDSCO, they are the Indian governing bodies. So this ICMR issued the policy statement on ethical consideration for human research in 1980. And the ethical guidelines for the biomedical research on human subjects was released in 2000, and it is in a gradual process of improvement. And the Central Drugs Standard Control Organization, so there is this Indian Good Clinical Practice which came in 2001 for the clinical trials. So there is a revised Schedule Y of the Drugs and Cosmetics Act that came in 1940, and along with the amendments in 2005, and it has been completely taken by the new drugs and clinical trial. That act came in 2019. So the ICMR and the Department of Biotechnology, they have formulated the guidelines for the stem cell research and therapy in 2007 and amendment in 2017. So there is this statement of general principle. So there is principle of essentiality. So that is the duly vetted by the ethics committee and of any institute or any, which can be a government institute or any private sector. Principle of voluntariness, the informed consent process ensures that the participants are safeguarded. Principle of non-exploitation, so equitably selected so that the benefits in the research are distributed fairly. Principle of social responsibility, so social harmony in community relationships, and principle of ensuring privacy as well as confidentiality. Principle of risk minimization, principle of professional competence is again very important aspect of these clinical trials, and principle of maximization of benefit, that is the benefit to the research participant and or to the society. And principle of institutional arrangements, principle of transparency, accountability, and principle of responsibility, and principle of environmental protection. Now coming to the categories of risk. So there are different categories of risk. So less than minimal risk. So probability of harm or discomfort anticipated in the research is less than minimal risk. And the minimal risk is the probability of harm or discomfort anticipated in the research that ordinarily encountered in routine life activity is little bit on the higher side, but there is no occurrence of serious harm or an adverse event is very unlikely. Then comes the minor increase over minimal risk or low risk. So there is increment in probability of harm or discomfort uh, with a little bit increase in the minimal risk threshold. More than minimal risk or high risk, so the probability of harm or discomfort anticipated in the research is more than the minimal risk. Examples include research involving any interventional study using a drug, device, or an invasive procedure such as lumbar puncture, lung or liver biopsy, endoscopic procedure. So again, the confidentiality, this conflict of interest is very important in all these research clinical trial. So there are responsibility bestowed over the research institutions as well as the researchers. So for the research institute, they developed policies and SOPs to address the conflict of interest issues that are dynamic, transparent, and active communication is there. And they must implement policies and procedures to address the COI and the conflicts of commitment and educate their staff about such policies. For the researchers, they must ensure that proper documentation is there and it is duly vetted and submitted to the ethical committee of their institute, along with the disclosure of the COI and especially the financial with or without interest. So this guard against the conflicts of commitment that may arise from situation that place demands on researchers' time as well as the loyalties. Then comes the important aspect, that is a research misconduct. So it includes the following. So fabrication is the intentional act of making up data, and falsification is manipulating research material, equipment or processes, and plagiarism is the wrongful appropriation and stealing and publication of the paper or of another author's language, thoughts, intellectual idea or expressions, representation of them as one's own original work or duplicating one's own. That is also known as self-plagiarism. Then comes the importance of the informed consent that needs to be there with all the clinical trial. This is a very important document. So it, as per the section 13 of the Indian Contract Act 1872. So the history is before our independence. So an informed consent form must include the following: the statement mentioning that it is a research, purpose and method, expected duration, benefits to the participant, any foreseeable risk, discomfort, extent to which confidentiality of record needs to be maintained, payment or reimbursement for the participant, free treatment or compensation, and freedom of the individual to participate or withdraw from research at any point of time, and the identity of the research team and contact person with the addresses. And there are special situations. So there is under section 53(1) of the Criminal Penal Code, and it came in light by the members of the Armed Forces, MOHA, Government of India, letter number this, dated 25th November 1972. So these are the vulnerable population like children, prisoners, pregnant women and fetuses, different culture or language, and terminally ill patient. So there are the rules of documentation for consent. So there are these different rules: FDA 21 CFR 50, 45 CFR 46. So a copy of informed consent shall be given to the participant or the representative, and the copy shall be given to the person signing the form. And good clinical practice, it came in vogue and it is still there, important aspect. and the subject must receive a copy of the signed with dated written informed consent form. And then there are institutional policies. So these are the clinical trial registries under the World Health Organization. And as you can see, in India, we also came under this tree in year 2007. And at that point of time, the total number of registered, and now the total number of registered trial in India is more than 20,000. So there is this role of CDSO, Drug Controller, this General of India, Clinical Trial Registry of India, ICMR, National Institute of the Medical Statistics. So there are how to go with any clinical trial. So there are different phases. So two ancient Indian scripts, that is the Charaka Samhita, a text of medicine, and Sushruta Samhita, a text of book of surgery, compiled as early as 200 BC and 200 AD, and currently estimated at 1,000 million US dollar. India's clinical research market has projected to cross 5 billion US dollar mark by 2030. And since April 2018, CTRI prospective registration is mandatory for all clinical trial. So there are these different phases. So phase 0 is an exploratory study conducted to find out whether any drug can modulate its intended target in human beings with respect to the body, or describe its metabolism. And phase 1 starts with the initial administration of any investigational drug in the humans. And the studies conducted in phase 1 typically involve estimation of initial safety and tolerability, pharmacokinetics, assessment of pharmacodynamics. And if needed, if CDSCO expert want to assess the toxicity level and then allow the human trial. Then comes the phase 2 that starts with the initiation of the study in which the primary efficacy, that is immunogenicity in case of vaccines in patients, is conducted on a group of patient or participant with a narrow criteria. Suppose if it is a lipid lowering drug, so it will be given in the high lipid patient profile. And then the phase 3. So it begins with the initiation of studies in which the primary objective is to demonstrate or confirm therapeutic benefit or protection rate in case of vaccines. And such studies are designed to confirm the evidence from phase 2 studies, plan to provide an adequate basis for impact on clinical practice and for the marketing approval, of course, and conducted to explore new uses of an already marketed drug like fenofibrate. So now it's a new regime that has been explored in cases of to stop the progression of the diabetic retinopathy, and also to plan as bridging the trials and pivotal trial. Phase 4, it begins after product approval. These are the post-marketing clinical trials. So phase 4 clinical trial, a study conducted to assess the safety, tolerability and effectiveness of a marketed product when prescribed in the usual manner in accordance with the terms of the marketing authorization, such as the efficacy and safety in special population. So in nutshell, preclinical, drug approved for testing in human, then phase 1, 100 participant, phase 2, 100 to 1000 participant, phase 3, 1000 to 3000 participant, and drug submitted for the FDA approval, FDA review, and they confirm the safety and the effectiveness. Then comes the post-marketing surveillance trial and the drug is approved. Now, composition of the ethical committee. So the members of the EC are chairperson, non-affiliated with the institute, qualification, a well-respected person from any background with prior experiences of having served or serving in an ethical committee. Member secretary affiliated with the institute and should have knowledge and experience in clinical research and ethics to be motivated and have good communication skills. And basic medical scientists who can be affiliated or non-affiliated, clinician, which again can be affiliated or non-affiliated, And qualification should be individual with recognized medical qualification, expertise, as well as training. Legal expert must be there. Affiliated or non-affiliated qualification should have a basic degree of law from a recognized university with experience, desirable training in medical law. And social scientist or philosopher, which can be affiliated or non-affiliated, and should be an individual with social or behavioral science. And lay person, non-affiliated qualification, literate person from the public or the community. So the quorum is required to pass any the project. So a minimum of 5 members needs to be present in the meeting room, and the quorum should include both medical, non-medical, or technical, as well as the lay men, the mandate. And minimum one non-affiliated member should be part of the quorum. Preferably the lay person should be part of the quorum. Now the classification of medical devices. So A, level of risk low, which are thermometers, bandages. B, low to moderate, hypodermic needles, suction equipment, or ophthalmic implants. They come in this B category of the medical devices. And moderate to high, the lung ventilator, bone fixation plate, high, heart valve, and implantable defibrillator. And placebo drugs. So they are part of the randomized controlled trial. So it can be used when there is no established effective therapy available, and if the disease is self-limited. And precaution to be taken when a placebo is administered. So it should have added safeguard to protect the participant, and use an add-on trial design, and expose fewer patients to placebo group, an active comparator as an additional arm. So it will be 2:2:1. So placebo will be 1, and ensure transition to standard of care or active medicine for study participants after research is completed, including post-trial arrangement for implementing any positive trial results. For the pregnancy and fetuses, very careful trial is needed. So appropriate studies or animal and non-pregnant individual should have finished before means administrating among this group. And the risk to the fetus must be the least possible risk. And researchers should not participate in decision making regarding any termination of pregnancy, and no procedural changes which will cause greater than minimal risk to this group. And then there are classification of drugs and formulation under the Ayush. So these are the classical preparation or formulation are those that are to be clinically evaluated and which are indicated for described in classical the literature. And these classical drugs are manufactured and named in accordance as described by the authoritative text. And patent or proprietary products are formulation containing only such product mentioned in the formula described in the authoritative book of Ayurveda. Conditions for the sham surgery. So there has to be a clear description of the justification to include a sham surgery in the protocol, and which has been carefully assessed by the ethical committee. And there must not be serious harm caused by the sham surgery. Now coming to the acts, rules, principles, and declaration. So there is Declaration of Helsinki, and it has been changed 5 times. And there is the controversy about use of placebo and post-trial access is debatable. So now there is Declaration on Human Genome and Human Right by the UNESCO, and the International Declaration on Human Gene Data, as well as the Universal Declaration on Bioethics and Human Rights. So as per the clinical trial since January 20, 2005, defined in Rule 122DA of the Cosmetic Act Rule 1945, so there is this clinical trial commerce versus the ethics, pharmacobase. So the research using the human beings should be selected so that the benefit of the research are distributed without arbitrariness and caprice. And research should abide by the principle of maximization of the benefits and interest and of distributive justice to benefit all humankind. And again, this rule of since January 20, 2005, clinical trial means a systematic study of new drugs on subjects and to generate data for discovering or verifying the pharmacological, including the pharmacodynamic as well as the pharmacokinetic, and to assess the adverse events. New drugs, more generally defined in act as a drug and not being used in the country to any significant extent in the condition prescribed and recommended or suggested in the labeling thereof, is not an investigational new drug. And then this again rule 122D of drugs and cosmetic rules define that no clinical trial for a new drug by an institution shall be conducted under in accordance with the permission in writing to the authority defined in clause B of rule 21.2. An application for grant of permission to conduct a human trial phase 1 on a new drug shall be made, and licensing authority in form 44 with a fee of 50,000 needs to be submitted along with all the information. And free medical management as long as required in case if there is harm or any side effect occurring to any clinical trial subject, financial compensation. In case a clinical trial results in the death of the subject, then compensation as per the order of the licensing authority. And the preceding subsections of the rule explain the circumstances as a direct nexus to an immediate cause to death consequences of non-payment of compensation. And the DAC rule specifies the prerequisite required for a clinical trial and to grant a permission by the licensing authority to conduct it on any human body. And the rule 122DD, it deals with the mandatory registration of the ethics committee, and the ethics committee needs to be on DHR, that is the Department of Health and Research, and there is an online website of Government of India, nethic.gov.in. We can go there and register our ethic committee. No ethic committee shall review and accord its approval as per the protocol without prior registration with the licensing authority, as is specified in the Appendix 8 of the Schedule Y, which has been totally replaced by the newer Drug and Clinical Trial Rule 2019. So how to assess the financial compensation? So this is the formula. So the percentage of permanent disability, C1 is equal to A into B in bracket 1 minus F by 100. C2 is equal to A into B in bracket 1 minus F by 100 into D divided by 100. A is the age of the subject, B is the income of the subject, D is the percentage of disability caused to the subject due to the clinical trial, and F represents risk factor, a scale of 0 to 100 to assess the severity of the disease. And sample collection and preservation. So it is important as per the IPC, Indian Penal Code, Section 201, and all relevant specimen or evidence must be collected, identified, and preserved appropriately. But there is a sorry state of affairs in India. So in 2013, the Indian Express states that the Indians are treated as guinea pig for these clinical trials by the multinational pharma majors, and very few cares to compensate the victims of the trial, and reveals data put out by the Union Health Ministry. Till April 2013, only 12 clinical trials were approved as compared to almost a 3-digit figure last year. And concern for the future of clinical trials in India. So country which is perceived as a fertile place for growth of clinical trial by the multinational giants, as more than 1,700 persons have died in clinical trial across the country between 2007 and 2010. So there is a total of 2,646 deaths and 14,616 serious adverse events were reported in January 2013 in Supreme Court by the Deputy Drug Controller of India. These are the Indian judiciary and medical legal bodies, so civil jurisdiction, civil courts, consumer protection forum, criminal jurisdiction, human rights commission, MCI, now National Medical Council, the IMA and the Women and Child Commission, SC/ST Commission, as well as different NGOs. So I will, this is the last part of my talk. So I will narrate a few cases which gone wrong. So first, the Democratic Women Association were the union of the Indian judgment. The Supreme Court first time took note of the fact that there was gross violation of the clinical trial guidelines and a symbolic acquiescence that the court must not tolerate such malpractices, and row over clinical trial as 254 Indian women death. So there was this 3-cluster randomized controlled trial for the screening treatment for the cervical cancer. And the screening treatment being examined were visual inspection using this VIA screening, as well as the pap smear, which is the standard of care in the West, as well as for the human papilloma virus. So it has justifiable aims and objectives. So there was this death of 254 Indian women from the modest background for this US-funded clinical trial. So where was the ethicality? Cervical cancer screening method, women who died were part of the group kept without screening to study death rate in unscreened the population. In fact, any kind of cervical screening reduces the incidence of the cervical cancer. And 140,000 women in the control arm of the trial were not at all screened. And after a complaint made to it, the US Office for Human Research, they confirmed that the women were not given adequate information in the informed consent. No money, be a Gwinnipeg. So the people involved were the Mumbai slums, villages in Usmanabad in Maharashtra, and Dindigul in Tamil Nadu. So the studies compared the cervical cancer death rate among more than 20 lakh population who were offered the different type of cervical screening in 138,000 women versus who were offered no screen at all. The Supreme Court said, why seriously affected clinical trial patients, they were not compensated. So this was the historical decision in reply to the PIL, so seeking the stringent yet transparent guidelines for clinical trial in India. And so the serious adverse event of deaths were 2,644, out of which 80 deaths were attributable to the clinical trial. So bench was focusing on the ministry's statement that around 11,000 serious side effects were there, excluding deaths, were reported during the period from January 1, 2005 to June 30, 2012, out of which 506 events were found to be related to the clinical trials. So as per this case between Swasthya Adhikar Manch versus Union of India, Apex Court criticized the government for its inaction in curbing the malpractices going on the clinical trial. Again, this case of Rahul Datta versus Union of India. So the Allahabad High Court considered the awarding the damages to the participants and came down hard on pharmaceutical companies for flouting the informed consent and causing the death of subjects and who were not at all aware of the fact that they were being used as guinea pigs. So who were the possible culprits? So these were all giants: Gates Foundation, Novo Nordisk, and the Senta Biotech. So in conclusion, as per the 59th report by the CDSO, so they have their own problems. So they said to the Ministry of Health and Family Welfare that 1045 posts are proposed, 327 were sanctioned, and only 127 were filled. Just 50 people to handle the applications for the drug approval. Just 9 deputy and assistant drug controller. They handle the 50,000 application of various types, inspecting labs, and 10,500 manufacturing units across India, providing information to Parliament, meeting the public, attending the court. And CDSCO is headed by a drug controller with a mere graduate degree in pharmacology. So there is a grossly inadequate infrastructure, including the data maintenance and to possible coordination between state level offices. So a comprehensive, what is to be required? A comprehensive legislation is necessary to build up accountability in clinical research, in human experimentation, to seal the vacuum in this area. As the existing implementation is necessary, it is neither so told competent, but is necessary to provide an effective machinery to ensure proper health care in the country. So these are the recommendations. So before approving the study in India, these points need to be considered by the Indian authority, whether the study is terminated or banned in any other country for any reason, whether Indian should be benefited by this medicine, and whether the foreign sponsors should hire a local clinical research and insurance company for conducting a clinical trial in India. Improve accountability through public access, informed consent, amend the law to address investigators' responsibilities, legal department for the protection of the vulnerable population, and the ethical regulation, improve the accountability and proper infrastructure, the places, whether it is government or the private sectors, they must be equipped with proper infrastructure and ensure the legality of the ethical committee. These are my references. So thank you so very much. You can't fix crazy, but all you can do is document it. Thank you
sir.
very much.
Yeah, thank you, sir, for addressing such a challenging topic with clarity and depth. So this is a very serious topic and which is often overlooked. Of those examples which sir has described at the end, that is very concerning. So may I request comments from the expert panelist?
Dr. Maurya, congratulations. You covered
Thank you. Thank you, Dayakar, sir.
You covered very well, extensively covered. So nowadays it's becoming mandatory for all residents to aware of all this, what is happening.
Yes.
So without institutional ethics committee board approval, they cannot submit their thesis either. Like they have to get an approval from the institutional board, then only the thesis will be accepted, initial registration. And then they should know about all the risk categories, outcomes, when to terminate, all that. So very well covered. Thank you very much.
Thank you, sir.
Excellent talk, Dr. Maurya. Fantastic talk. Just goes to show how much you're prepared for this. I just have one question regarding that cervical cancer deaths which you are talking about. How did the patients actually die? Were they all cervical cancer patients who were not treated or just observed vis-a-vis the people who are treated, or was it a vaccine which was tried on those patients? How did so many people die?
So there were 3 groups in that study, right, sir? So the one of the population was not at all screened. And as you know, that screening prevents, this screening helps in identifying the early cervical cancer and the management.
Okay.
So for the 1,38,000 of the female population, they were not at all screened. Right. Okay. For 5 to 10 years, this study was going on.
What was the study about? Just screening, is it? That's all.
Screening method for a new screening method in this human papilloma virus, this causing the cervical cancer.
Okay.
So that was historic means that thing happened in India, and the Supreme Court was very meticulous in the next clinical trials, whichever is happening in India. So they were very specific that stringent SOPs and rules needs to be followed in the coming clinical trials. And they were quite skeptical about the role of these multinational giants.
Yeah, absolutely. Yeah, because 200 deaths is a big number.
Yeah.
Huge number. Thank you, Dr. Maurya. Thank you.
And 11,000 were serious adverse event.
Adverse, okay.
Dr. Kirti or Dr. Seema, can we have comments from you?
No, I think it was extremely. Yes, please go on, man.
Yes, Dr. Seema, you can go ahead. You're muted.
Dr. Seema, kindly unmute yourself.
Yeah. I was saying, it was a.
Dr. Seema, you're muted again.
So I don't know. Am I audible now?
Yes, you are. You are, ma'am.
Yeah. Sorry, I think I am in a little bad network zone. So I just wanted to congratulate Dr. Maurya. It was a very informative talk, and I really learned a lot. And thank you very much for pointing out all the the smaller things also. which as clinicians, these are very important things. As clinician, we often don't talk about those things. And I think it's very important that, these are part of at least the residency training curriculum, a little bit of it we all should be aware about. And thanks a lot for highlighting this. Thank you very much.
Thank you, Dr. Seema ma'am. I've already requested for one chapter on this thing for all the residents and fellows. And because I am CDSCO external expert from the ophthalmology field for the CDSCO Government of India. So that's why I want this chapter to be there for all the residents. We must know the minute details, how to go ahead and do any clinical trial or any study with humans.
Right. And this will be really useful. Yeah. Thank you very much.
Thank you, ma'am.
Yes, sir, Dr. Maurya, amazing talk. A topic
Thank you,
that
ma'am.
most people would like to run away from. Very important for postgraduates to know, because many of us start our thesis not even knowing what a trial is about, how to go about doing any of this. It's Greek and Latin to most of us because it's never covered even in the MBBS curriculum. It's just touched upon a little bit, but nothing in detail. And then you're just thrown into this vast ocean of how to do a trial. So very excellent talk. And yes, if it comes into as a chapter, that will be very useful for all the postgraduates, and not just postgraduates, even for clinicians, because anytime we want to do research or anything, these are certain things that we need to keep in mind before we do any kind of study. Thank you.
Thank you, Kirti ma'am.
Thank you so much, Arvind sir. You really opened our mind to a new
Thank
topic.
you, everyone. Thank you so very much.
Over to you, Shebin.
Okay, so if there is no other questions, let us move to the next topic by Dr. Nisar Sonam Poonam, which is an approach to case of proptosis. Over to you, ma'am.
Hi, and good morning, everybody. I think after Dr. Maurya, I need some time because there's so much of amazing information there. I'm just gonna share my slide. Are my slides visible now?
Yes, they are. It's still not in slide share mode, Dr. Sonam.
Right. All right. So yes, this can come as a long case for the postgraduates for examination as well as a long question. So let's move on to an approach to a case of proptosis. So what is proptosis first? Pro means forward and ptosis means displacement. So it's a forward displacement of the globe. Now, today's topic, we're just going to cover what are the definitions, the classification, etiology, a detailed examination, and few case scenarios and take-home messages for the postgraduates. So there are some terminologies that we all must be aware of while dealing with the case of proptosis. So first, as I mentioned, is proptosis as a forward displacement of the globe. Then you have the term that is exophthalmos. So that is generally used in association with any endocrinology associated proptosis, like a thyroid-related orbitopathy. Then you have another term that we commonly use, and that is a dystopia. That is an abaxial displacement of the globe. And then, of course, we have a condition that is pseudoproptosis, wherein you think that the eye does look prominent and big, but for all you know, the other eye might be ptotic, or the actually affected eye might have a lid retraction, but no forward displacement of the globe. So now, based on the displacement, you can classify your proptosis as axial or abaxial. Then based on the laterality into unilateral or bilateral, based on the duration as acute, subacute, chronic, and whether there is associated pulsatility into true or pseudopulsatile proptosis. So as you can see that axial proptosis is generally seen in thyroid orbitopathy or optic nerve lesions, whereas lesions anywhere else can cause abaxial proptosis. Etiology-wise, it's the same as any other lesions. You can have vascular lesions causing proptosis like lymphatic malformations, capillary hemangiomas, inflammatory lesions or inflammatory orbital disease, IgG4-related disease, infectious etiologies such as tuberculosis or cysticercosis, bacterial or fungal orbital cellulitis causing proptosis, post-trauma like in a blow-in fracture or subperiosteal hematoma, you can have proptosis. You can have proptosis because of one entire plethora of neoplastic lesions that can happen in the orbit, and cysts such as dermoid cysts, hydatid cysts, and so on and so forth. So as a postgraduate, it is important for us to know the anatomy of the orbit. Once you know the anatomy, it is easy for us to understand or pinpoint where exactly the lesion is originating from, or what is the position of the lesion at least. So as we know, the Lacrimal gland is located in the superior temporal quadrant of the orbit. You have the lacrimal sac, which is in the lacrimal sac fossa inferior medially. You have the maxillary sinus inferiorly. You have the frontal sinus superiorly. And medially, you have the ethmoid sinuses. Of course, it is also important to know the various spaces in and around the orbit. So anything within the extraocular muscle cone is an intraconal space. Outside the extraocular muscle cone is the extraconal space. Then you have between the periosteum and the bone, that is a subperiosteal space. And between the tenons is the subtenon space. Now, going with this, it is very important to go back to our medicine days and surgery days, and history taking is extremely, extremely important. They say that 70% of your provisional diagnosis can be achieved by just a very good detailed history taking, then local examination, then ocular examination. By local examination, I mean the examination of the orbit. Then ocular examination on slit lamp, your anterior and posterior segment, systemic evaluation such as looking at the other aspects such as any regional lymph nodes, the parotids, the oral cavity, the nasal cavity. In case of suspected metastasis, you even have to examine the breast and the prostate as well if we can. Then comes your investigations and imaging. So as a resident, based on just the onset, whether it is acute, subacute, or chronic, you have these distinctions that can actually happen. You can have infectious etiology because that is generally more acute in nature, inflammatory lesions, vascular lesions which bleed like a venolymphatic malformation with an acute bleed can present with acute onset. Subacute or chronic, most common is thyroid eye disease, which is generally progressive. You can have dermoid cyst, which is lying there for years together. You can have neurofibroma, you can have gliomas. And based on age also of the patient, like less than 2 years, more commonly we see either dermoid cysts, congenital cysts, we see capillary hemangiomas of infancy. Between 2 years to 16 years, it can be based on the history, whether there was any associated trauma, infection, any history of cold, cough, fever. You can have neoplastic lesions and neurogenic mesenchymal lesions. Vascular such as venolymphatic malformation with an acute bleed can present also between 2 to 16 years of age. Between 17 to 64 years of age, generally you see more of thyroid orbitopathies, you see lymphoproliferative lesions. You might have a slow-growing cavernous hemangioma or schwannomas. Inflammatory lesions, if they are associated with pain, you can have IOID or IgG4 orbital diseases. And more than 64 years, generally we look at any kind of a malignancy in general, besides all the other differentials. So going back to the history, we have to ask for the history of presenting illness, chief complaints, duration, any associated symptoms, past history of any surgical or any systemic complaints is very, very important in any orbital evaluation. Now, we should remember the 6 P's of orbit, and this has been described by Crowell, Stewart, and Chavez way back in 1980s. You have to ask if the patient has any associated pain, it is progressive in nature, or it is status quo, whether there is prominence of the globe, which is axial or abaxial. We have to palpate. We have to look for any pulsations, and very important is also to look at the whole face and any periorbital changes. For example, in the case of neurofibromatosis, you look at the patient, there might be caffeolate spots, you might have a plexiform neurofibroma, probably this is a case of a neurofibroma, right? So now coming on to the inspection, when you look at the patient, we go back again to what I first said as classification, whether it is unilateral, it is bilateral, whether it is axial, abaxial. If there is a picture like this, where there is complete ptosis, you lift up the lid and you evaluate the patient lifting up the lid. Worm's hole view is a fantastic, just inspectory finding where you can actually ask the patient to look up and look right there, and you'll see whether the patient has any mild or moderate or severe ptosis, as you can see in this picture. Very important also when you have medial canthal lesions, especially in pediatric age group where your child may not be very cooperative. You have to see where the lesion is going. If it is going anywhere 5 to 6 millimeters above the medial canthal tendon, that might be a little suspicious. So these are the few things that you must look just at inspection. Now coming on to the examination. When you look, you do exactly everything that you do probably in a ptosis workup. You actually check the palpebral fissure height of the patient by asking the patient to look in straight gaze, negating the action of the LPS. You measure the palpebral fissure height. Bilaterally, you measure MRD1, MRD2. It's very important. If you have an associated squint, you fix the squinting eye and then you take all the measurements, even when you're doing the Hertel's exophthalmometry. As you know, this is the Berkey's method of assessing the LPS action and the lid crease. Next, coming on to the other examination. If you're looking at this kind of a picture, you know that there is a lid retraction, both upper and lower. You have to measure the superior scleral show and the inferior scleral show as well. You have to measure the amount of lag of thalamus in this case. Extraocular motility examination, very, very important. And also it is important to look at the Bell's phenomena in case of proptosis, because patients might come to you with nocturnal lag of thalamus and exposure changes as well. Now you also look at the type of ptosis that is there, whether there's an S-shaped ptosis, you have a medial droop or you have a lateral droop. Very important when we're looking at it. Look at this picture. You see that there is a fullness in the upper eyelid. You can see that there is a superior orbital mass, but you also look at the engorged veins there. And that might give you an idea that this is probably a vascular lesion on palpation. Besides that, we have to then go on to the examination of the mass. So you palpate all the orbital rims, you palpate the mass. A finger insinuation test is very, very important, so that you can mention whether the mass, whether you're able to insinuate the finger between the globe and the mass, or the mass and the orbital rim. If you cannot insinuate the globe, then probably the mass is infiltrating either towards the globe or there's a bony erosion associated with it as well. When you're looking at a mass, you can also look at all the other findings that we described in a surgery, like whether the mass is well circumscribed, it is ill-defined, it is mobile, whether it is adherent to the underlying skin, overlying skin, or the underlying bone, whether it is compressible, whether there is any associated pulsations there or not. So all those findings are something that we must assess here. So as you can see in this video, when you look and you put a finger there, you also look at retrobulbar resistance. Also, you can see the classic pulsatility that you can see in a case of a direct CCF. As you see in this picture, you can see that we are not able to insinuate the finger between the mass and the superior orbital rim, and there is an extension and erosion of the bone in this patient. You can see that there is an inferomedial globe dystropia. So definitely there is something in the superior temporal quadrant which is pushing the globe down and inside. So looking at the type of dystropia also will tell you approximately where your mass is located. Now coming on to the measuring of the proptosis. So when you're looking at measuring proptosis, you have Lude's exophthalmometer, you have Hertel's, and if nothing is available in the examination, then the best way to measure the dystropia and proptosis is by two-scale test that is there, and by just keeping a transparent scale at the lateral orbital rim and measuring, looking at the at the corneal apex and seeing how much amount of globe is outside away from the lateral orbital rim. Then it is very important to obviously palpate your regional lymph nodes. Next is your anterior segment evaluation, which as ophthalmologists, all of us are very well aware with. We must do a gonioscopy also in cases like CCF. If there is blood in Schelm's canal, gonioscopy to look for any secondary increased intraocular pressure, secondary to increased orbital pressure. And of course, stain the cornea, look for any exposure changes as well. Next is the posterior segment evaluation. Very, very important is optic nerve function tests. Begins with vision, with pinhole also you must check. Contrast sensitivity, which is one of the most sensitive tests to look for any compressive optic neuropathy. Then color vision, of course, pupillary evaluation to look for any RAPD or anisocoria or a dilated pupil, or a mediatic pupil post-trauma that you can see. Then evaluation of the fundus in order to look for any compressive neuropathy, any optociliary shunts in the case of meningiomas. Very important is also to do a visual fields. We generally do a 30-2 HVF, that is Humphrey's visual field, in order to look for any changes there. And when in doubt, you can also do a VEP to look for any optic nerve compressive changes. Now, when you're looking at a patient like this, you can see that one eye looks fine, but the other eye looks ptotic. Now, the patient, go back to history. The patient did give a history of thyroid disorder. And there, a simple eye SPAC test in your OPD can actually confirm the diagnosis of a myasthenia gravis in a case of thyroid eye disease as well. So keep our eyes very handy in the OPD. And of course, not to forget, like in cases of any proptosis, we must evaluate the Valsalva also to rule out any venous malformations. So these are the most important tests. One thing that we should not forget is to examine the entire face. As you can see here, this patient has mitosis, proptosis, fullness of the cheek. You can see some bleeding from the nose. The moment he opens his mouth, you can see that there is a necrosis of one side of the palate. This was a case of mucormycosis here. So this is something that is very, very important. Just doesn't end with the eyes or the orbit. You have to examine the entire face. Now, let's say you have this kind of a dystopia, like I was mentioning before itself. You know the eye is down and out. So the lesion is somewhere in the superior medial orbit. Then here you can see that the eye is moved up. So that means there is some lesion right here in the inferior orbit. So based on the location also, we can just come to some provisional diagnosis, whether if it's an axial displacement, it's an intraconal lesion like a cavernous malformation or a schwannoma. You can have enlargement of just extraocular muscles and increase in orbital fat, like in thyroid orbitopathies, or any optic nerve tumors that can be a meningioma or glioma. But this is not necessary. If you have an optic nerve tumor with a deterioration of vision, you can have associated squint and proptosis also. Abaxial proptosis, like I was telling you, whatever direction your globe has been moved in, opposite to that, you can have the lesions in that direction. So now, based on your history, your clinical examination, you can come to a provisional diagnosis of what kind of a lesion are we dealing with. If it is associated with pain, is it inflammatory? If it is painless, is it non-inflammatory? Whether it is just a simple thyroid eye disease or it is some kind of a neoplasia, whether it is there since birth, like a dermoid cyst, or it has been acute in nature, like probably a bleed with a VLM. Now, imaging is just an adjunct for us. And as postgraduates, there's always a dilemma when to advise for a CT scan versus an MRI. So as we know that CT scan mainly gives a fantastic idea on your bony lesions, whether there is any associated erosion, orbital fractures, like in post-trauma, if there is a subperiosteal hematoma. So these are the conditions where you can advise for a CT scan. More or less, we love to advise for an MRI because it gives us a very good understanding of the soft tissue lesions, whether there are any vascular lesions, contents of the cyst also are very well delineated. The type of infiltration, if it's a tumor, whether it's infiltrated into the extraocular muscles, whether it's gone through the cavernous sinus, into lying in the skull base, all those things will be better understood on MRI. So these are just few indications where we would like to do a CT scan, but otherwise MRI is a better choice of investigation. When you know that there is a dermoid and a dumbbell dermoid especially, there you can see that there is an intraorbital and an extraorbital extension, like in the case of dumbbell dermoid. Post-trauma, like you can see here, the patient has proptosis with upper and lower lid edema, and you can see that there is a trauma and there is a lot of air pockets here. So this is a case of emphysema. Next, you can see here when you're planning an orbital decompression, like in the case of thyroid eye disease, or to see whether if any augmented decompression is required post a primary decompression, you can do a CT scan. So these are the indications really for a CT scan examination. Now here you see you have a 50-year-old male patient. You can see that the patient has proptosis, congestion, and he presented to us with deterioration of vision over the past 1 month duration. He was hypothyroid on treatment. As you see, the vision has deteriorated to 636 in both the eyes. We must obviously look at the pupils, the color vision, and exophthalmometry findings. There was a proptosis 27 and 26. The visa inflammatory score here, you can see that there is a caruncular edema, there is a congestion, upper lid fullness is also there. So this was a case of active thyroid eye disease with a dysthyroid optic neuropathy. You can see optic nerve compression here. We did a field test. Next investigation will be to look and document for the fields. So a HPF confirms that there is a GRS, that is a generalized reduction in the sensitivity. We did a diplopia charting also just to document the amount of diplopia that is there, and a VP. So all this documentation is very important. You know that the optic nerve is involved, but as a resident now, we just had a class on medical legal aspects also before this. It is important to document this also before planning any intervention. Next, we do an MRI. MRI will tell us the activity of the muscles and the compression at the level of the optic nerve. So you see here that the Barrett's index that is taken at the mid-orbit level, suggestive of a compressive optic neuropathy. And the muscles should lead to hyperintense signal. So the management for this is definitely 1 gram IVMP for 3 days, then followed by a decompression, and then we treated this patient with IVMP pulse and immunomodulators. And here you can see the post-op result. One of the beautiful ways to document or learn about how to assess a case of a thyroid eye disease or even any proptosis, according to me, is this visa form. As you see, the visa form has all the details that would be required for assessing and managing your thyroid eye disease. So here it takes care of all your symptoms, your history, everything. Most importantly, this examination finding, that is vision, inflammation, strabismus, and appearance, which tells you everything from palpable fissure height, your MRD1, 2, your superior scleral show, inferior scleral show, levator function, exophthalmometry findings, even cornea and IOP in straight gaze and up gaze can be mentioned here. So if as postgraduates, you can get a hold of this form, which is available very easily online, then your evaluation of a large case of a thyroid orbitopathy is very easy here. Right? And this is how we ask all our postgraduates and fellows also to fill this form. Now let's go on to some case scenarios. Here is a 2-year-old child who had fever since 10 days and an inferior globe dystopia. Febrile, young child with sudden onset globe dystopia and an imaging picture like this. The first thing that we can do just in our lab is do a peripheral smear. If it shows your blast cells, that means probably this is a case of leukemia, and immediately you can refer the patient to a medical oncologist. Here is a child who came to us with history of fever, cold, and cough since 5 days and sudden onset proptosis. As you can clearly see in the imaging, this is a case of orbital cellulitis with a subperiosteal abscess and an ethmoid sinusitis. Patient was treated with antibiotics and taken up for endoscopic aspiration of the abscess, drainage of the abscess. So as per Chandler's classification, it is very important for us also to rule out as postgraduates between a preseptal and orbital cellulitis. But there are 5 stages of an orbital inflammation: preseptal cellulitis, orbital cellulitis, subperiosteal abscess, orbital abscess, and eventually it can cause vision-threatening cavernous sinus thrombosis. So as postgraduates, it is important to note that just a preseptal cellulitis may not always have fever, proptosis, extraocular motility restriction, increase in retrobulbar resistance, but all these things will be present in an orbital cellulitis. Preseptal generally has a lot of lid inflammation and chemosis, and you should not mistake it for an orbital cellulitis. Here is another case. As you can see, this is a 5-year-old boy with sudden onset of proptosis and just a history of cold. If you see, there is a proptosis with subconjunctival hemorrhage and chemosis. If you see here clearly, you can see fluid levels in the imaging. It is a case of venolymphatic malformation, which is treated with multiple injections of bleomycin and is doing beautifully well. Now, a very important evaluation, if you look at this patient, you see there's a subtle superior sulcus deformity, but if you look at it otherwise, it looks almost symmetrical. There is no proptosis. The palpable fissure height also looks very symmetrical, but the patient says every time she bends down and comes forward, she feels heaviness in the eyes and the lids. And you can see here, this is a case of an orbital varix post-Valsalva. You can see the increase in proptosis and ptosis here, and the patient was quite symptomatic, treated with bleomycin again. Now here is another child. As you can see, this is something that we commonly come across. You can see the very beautiful strawberry spots. You can see a mass in the upper eyelid and in the orbit, and you can see complete mechanical ptosis here. This is nothing but a capillary hemangioma of infancy. It can be treated beautifully with just an oral propranolol. Works very well, 0.2 milligrams per kg body weight, and then you can hike up to 2 milligram per kg body weight, and works beautifully well. Now, another thing, this is a 4-year-old boy with gradual painless proptosis associated with decrease in vision. On imaging, this is a case of an optic nerve glioma. As you can see, because there's a decrease in vision, the patient also had associated squinting. So not all cases of optic nerve gliomas may present with just axial proptosis. Here is a patient who just had proptosis on the left hand. Imaging showed a classic tram track appearance and optic nerve sheath meningioma. A beautiful imaging is also a diffusion weighted imaging, which tells you about the cellularity of the lesion. Now here is a very classic CCF. As you can see, the classic 3 signs of a CCF. You have to ask for any tinnitus, pulsatile proptosis, and corkscrew vessels. You can see corkscrew vessels. The patient did come with tinnitus, and when you just put a finger on top, you'll see that there is pulsations. This is only seen in direct CCF, not in indirect CCF. When you do an imaging, if it is draining into the orbit, you will see this huge superior ophthalmic vein, which is dilated. So this is a case of post-traumatic CCF. Here is a patient who came to us with acute onset proptosis. The parents just gave us a mild history of trivial trauma. You can see the entire orbit is filled with a lesion, and not just that, even has lesions in the cheek. An incision biopsy was done for this child. This turned out to be a case of rhabdomyosarcoma and was treated with chemotherapy. Sorry, I think I'm going back. Okay, here is a patient who presented to us with painful diplopia. So when he looks in abduction, there is a lot of pain, there is mild congestion. He had waxing and banning symptoms. And on imaging, you can see that there is a tendon involving enlargement of the lateral rectus muscle, confirms the diagnosis of an IOID, and was treated with oral steroids. Here is another patient. As you can see, there is a subtle S-shaped ptosis. There's an inferior globe dystropia and a fullness in the superior temporal quadrant. If you look at it clearly, there is a mass in the superior temporal quadrant and there is a remodeling of the bone. This was a case of a pleomorphic adenoma and was just excised in toto. So just a take-home message for the postgraduate. Yes, orbit is a Pandora's box, but it is very easy if you follow the basic principles while examining, proper history taking, evaluation properly, as I discussed. When you're looking at a mass, you look at the lock is the synonym, the mnemonic, sorry. That's the location. You look at the onset, clinical features, and of course, it is very important to know your anatomy. So that's it. That's how you would examine a case of proptosis. I hope this is useful. Thank you so much. I'm going to stop my screen share.
Thank you, ma'am. Very beautiful talk. So we know that proptosis is like, just like a jigsaw puzzle, where you just have to put the puzzle pieces in the correct places. That is your examination findings that ma'am has described very meticulously and systematically. So just one question, ma'am. So which like CT or MRI, which one you will prefer? Or do you have any guidelines for that?
So we generally prefer, like I said, an MRI in all patients where we suspecting an orbital lesion or a case of thyroid eye disease. But in case, like I said, the few differentials, you know that this is probably a dermoid, then we prefer for a pediatric protocol CT scan. And with the pediatric protocol, there's not so much risk of radiation as well. Second, post-trauma. When you want to look at any orbital fractures, you want to look at any subperiosteal hematoma, that is another indication for CT scan for us, or any bony lesions. When you palpate, and if you see the lesion is very bony hard, then probably this is one of the kinds of osteomas or fibrous dysplasia or something, then you definitely need an CT scan also.
Okay, so let us, may I repeat the comments from the expert panel? Dr. Senthilnathan, sir.
Yeah, excellent talk, Sonam, as usual, very elaborately covered completely from the beginning. And I think the PGs also have to learn how to measure proptosis. That's very important, especially in exams. You should know how to use a hurtles. So if you're not used to hurtles, you have to go and see the equipment and learn how to use it. That's very important, because even in your practicals, they might give you a hurtles and ask you to use it. So you have to be familiar with that. That's very important. And again, apart from that, I think Dr. Sonam has covered almost all the ways of investigating a patient, how to work up a proptosis patient, or how to clinically examine. Measurement is something which you have to really know, because that is for documentation is very important. So even if you don't have a hurtles, using a Lude's method or a 2-scale method for eccentric proptosis, all that is what they will expect in the examination. How to measure proptosis is that's an important thing. Again, the radiology is important, CT, MRI, like what Dr. Sonam was saying. Whenever you have a bony pathology, suppose it's a fracture, there's no point in ordering MRI, because in MRI the bone will not be visualized at all. So if it is a fracture, you have to always order only a CT scan. And also, what are the different views in a fracture patient? You should also order a sagittal cut, which is very important. Normally we order axial coronal, but if it's a fracture, you have to also order a sagittal cut, because you need to see the posterior extent of the fracture, whether they have a posterior ledge where you can place the implant. If they don't have a posterior edge, then you have to order a different type of implant which can be fixed anteriorly. All that decision making, it's very important for you to order a sagittal cut. And apart from that, I think thyroid again is very important. In a proptosis, thyroid is a commonly kept case. So you have to know the classifications of the current classifications of thyroid ophthalmopathy, all the different types of CAS and visa and all those classifications you have to know very well. So all these are expected when you go for your examinations. So apart from that, I think she has done a great job. She's covered everything. And this reading up regarding the classifications and measurements, all that will be expected in the examinations, which they might have to read up separately. Thank you, Dr. Sonam. Thank you.
Dr. Kirti ma'am, Dr. Seema Das, ma'am, any comments?
Thank you, Dr. Sonam. Very well covered. All the topics were really beautifully covered by you. And this is a very important topic for postgraduates. Usually, there will be a thyroid or some kind of proptosis long case which will be there in the practicals, and you even in the essay questions they do ask about different like classification of proptosis. So she's covered the stepwise examination of how to examine. It's just always important to remember the side headings when you're doing. Again, oculoplasty is one topic which is always kept to the last. People always concentrate on glaucoma, retina, cornea, but they always forget about oculoplasty. But you can have this as a long case. So try to take some cases of proptosis, examine them, see how to palpate, inspection, palpation, auscultation, Rui. All these things you need to try and do it once at least in your OPD before you go for your exam. You can't directly go there and do it. You need to know the definitions, proptosis, exophthalmos, what is dystopia. These are small, simple things that the examiner can ask you. Unilateral versus bilateral proptosis differences. Proptosis in a child, malignant, benign, most common causes, and then malignant, benign in an adult. These are some basic questions which the examiners will ask you. Thyroid, cavernous hemangioma, capillary hemangioma, lymphangioma, dermoid. These are things you need to know at the tip of your fingers when you go in. Also classifications for IOID. So if you cover these basic things in proptosis, it is very useful for postgraduates for their examinations. Okay, yeah. Thank you.
Any comment?
Thank you, Dr. Sonam. I think it's a very kind of very well covered topic. Proptosis is a vast topic, and I think you have covered it really well. The approach, and it's going to be very important or useful resource maybe for the postgraduates to listen to this talk maybe later on. And I think as far as evaluation is concerned, proptosis evaluation is something which has nothing much has changed since the time of Duke Elder probably. And whenever an examiner comes, they are going to stick to the basics. So what we have been doing it for the past maybe 30, 40 years, it still holds true when it comes to evaluation. And many a times the examiners are really fond of asking the basics, which sometimes we tend to miss out these days while trying to focus on the management, making a differential diagnosis. So this aspect is very important to know the basics of the evaluation, the smaller things, and even the old terminologies. Many of them are very fond of asking those old terminologies also that I mentioned in once. So those are something which are very important to be aware about. And from each disease category, once we are able to make a differential diagnosis, it's important to know at least a little bit more about the most common etiology in each disease category. So if it's a proptosis, long-standing in an adult where we are suspecting a benign etiology, it's going to be important to know a little bit more about at least one cause for that, maybe a cavernous hemangioma, and go into the depth of it. So if we just take that approach, at least most of the proptosis we'll be able to cover for Viva or for a long question also. Yeah, thank you, Sonam, very much. You really covered it very well.
Thank you.
Hello.
Yes, sir.
Yeah, yes, sir.
Dr. Sonam, you covered very well. Like the most of the postgraduates, when the proptosis comes, like the case comes, like they directly look into the proptosis examination. So sometimes they present as otheritosis. So completely they miss the diagnosis. That's the first thing. Second thing, the history point, like in the thyroid patient comes, they forget to ask for a weight loss, weight gain, hypothyroidism symptoms. They won't cover at all. Like so we need to re-emphasize that we need to examine, and we need to, before examination, ask in the history, like a sleep disturbances, weight loss, or menstrual abnormalities. They will not ask. Similarly, in the general examination, they don't look at thyroid gland. So much big swelling will be sitting in the
that has been there for many years together. So that is one thing. And also the MRD. There's actually classification for lid retraction, also the thyroid eye disease. An MRD of 5, MRD1 of 5 to 7, and more than 7 is mild, moderate, and severe lid retraction. So that's another thing that they can go and refer.
Excellent, excellent. Thank you.
Thank you, sir.
Covered very well.
Thank you so much, sir.
Thank you so much, Dr. Sonam. I really like the point where you said visual fields is very important in doing them in a case of proptosis. That was a very important point. I also, Dr. Aparna is asking any PG reading material for proptosis that you would like to suggest here.
Normally, most of our postgrads, they read Zia Chaudhary. So I think that is one book that they read. More or less, we at Shankanetra, we actually have a folder for proptosis evaluation. So we hand out that's a handout that is given to all our postgraduates and fellows when they come into the department. So that is something that we've made not just for proptosis, but also for lacrimal evaluation and ptosis. That is something that is given to all. We can share that if required, if anybody would like that.
Thank you, Doctor.
Thank you.
So if there is no other comments, shall we go to our next topic that is more related to our proptosis? So next is on orbital tumors by Dr. Swatishree Naik. Over to you now.
Yeah, so a very good morning. Is my screen visible?
Yes, Doctor, it's visible and you're audible.
Yeah, yes, now your screen is visible.
Okay, so good morning. I'm Dr. Swatishree, working as an associate professor at AIIMS Guwahati. My topic for today is orbital tumors. I have no financial or proprietary interest to disclose. So the fact is, why orbital tumors are difficult for the residents. Now, orbit is a very compact space which encompasses the globe, the optic nerve, multiple neurovascular structures, and complex musculotendinous structures, all of which are required for the precise orchestration of ocular movements. So if the tumors, span a wide spectrum, they can originate in this anatomical region. So there are multiple tissues which are very packed in a very small space, and the symptoms, they overlap across the benign and malignant lesions. And so if you have correctly localized, it simplifies the diagnosis. Now, the learning objectives would be to localize the orbital masses clinically, to recognize the classical imaging patterns, and to differentiate between benign and malignant tumors, and approach management logically. So to define orbital tumors are benign or malignant lesions which arise from or secondarily involve the orbital contents excluding the globe, but they include the optic nerve, the extraocular muscles, the lacrimal gland, the orbital fat, vessels, nerves, and bone. Now, this is a schematic representation to understand the orientation of the bilateral orbits, where you can envisage them as recombinant pyramids. The lateral walls, they subtend an angle of 90 degrees with each other, while the medial walls are parallel. Now, if you come to the orbital anatomy, it follows the rule of 7. So it has 7 bones, 7 muscles, and 7 nerves. So orbital walls, they're formed by the 7 bones, which are the orbital plate of the frontal, the ethmoid, the lacrimal, the palatine, the maxilla, the sphenoid, both greater and lesser wing, and the zygomatic bone. So again, coming to the muscles, it involves 7 muscles, like the 4 extraocular muscles, the 2 obliques, along with the levator palpebrae superioris. Now, there are also 7 nerves inside it: the optic nerve, the oculomotor nerve, the abducens nerve, the trochlear nerve, the lacrimal, the frontal nasociliary branch of the ophthalmic division of the trigeminal nerve. Now, the key concept when we deal with with the orbital tumors is to understand the orbital compartment. So intraconal, it has already been explained by the previous speaker, but if it is located within the muscle cone, broadly we can tell it as intraconal. Extraconal if it is outside. Orbital apex when it involves the posterior orbit, or a diffuser infiltrative pattern. So this diagram, you can see the green color, it represents the intraconal space which is bounded by the extraocular muscles. So the yellow color, it is the peripheral space or the extraconal space. Then the subperiosteal, it is the blue shaded space, and the subtenons, it is the teal-shaped area, and the subarachnoid space, which is within the optic nerve sheath. Now, how do we approach these orbital masses? So onset, we should see whether it is an acute or a subacute or a chronic a lesion, whether it is painful or it is painless, whether it is leading to an axial or a non-axial proptosis, and whether there is associated vision loss and diplopia. So these 4 things would help us to, it helps us in the diagnosis of these tumors. Now, some examples are, if it is an axial proptosis, we are basically dealing with intraconal lesions. If it is non-axial proptosis, then we are dealing with extraconal lesion. And if it is leading to early vision loss plus ophthalmoplegia, then basically we are dealing with some apical lesions. Now coming to the radiological findings, multiplanar thin slice, these imaging is very important in case of orbital tumors, and multiplanar thin slice MRI with fat suppression and gadolinium enhanced images, they help us delineate the orbital soft tissue, and they clearly depict the orbital apex and optic pathway. The CT scan, as it was discussed in the previous presentation also, it helps when we are talking about the bony lesions, it serves a better purpose. Now, considering the shape of the lesions, when it is basically, it is a, we tell that it is, we can think of it as a benign lesion when it is oval shaped and it causes displacement and deformation of the adjacent anatomical structures. But in case of malignant lesions, we can see that it is very irregular, infiltrative, and diffuse in nature with perineural involvement and bony destruction. Now, the orbital tumors, it can be, although there are several ways to classify, but if we go by the, since it is consisting of several kinds of tissues in that compact space, we can go with the from where the tumor is originating, and we can classify according to that. So it can be of vascular origin. So the coming to the vascular tumors and malformations, they're more or less they're divided into three types. The first type is where there is no flow, where we are dealing with the cavernous hemangioma and the lymphangioma. Type 2, where there is mid flow, we are dealing with the orbital varices, and type 3 is high flow or the AV malformations. Now coming to the cavernous hemangioma, it is the most common benign orbital tumor in adults. It is usually seen in those middle-aged females. It's a slow-growing intraconal and non-infiltrative lesion. It has a 87% of cases, they have a propensity to occur in the intraconal space and lateral to the optic nerve. So the distribution, it mirrors the distribution of the small arteries and arterioles that are there in the orbit. So when we do an imaging, we can see that it is a hyper-intense, well-defined intraconal mass with homogeneous enhancement. The histopathology, we can see these large cavernous vascular channels which are filled with blood, and they're lined by a single layer of latent endothelial cells, and they're separated by scant connective tissue stroma. A fibrous pseudocapsule can be seen surrounding the lesion. So if we have an adult who is presenting with a painless axial proptosis, a well-circumscribed intraconal lesion, then we are dealing with cavernous hemangioma, and complete excision is curative. Now coming to the next tumor, which is lymphangioma, it's a type 1 vascular malformation. Although it is a benign entity, it may progress to severe globe displacement and cosmetic disfigurement. So it can be both microcystic, where it is less than 1 cm, or macrocystic, where it is more than 1 cm. The challenge is due to the diffuse nature of the tumor and the associated bleeding. Now, surgical debulking is advised, but after intralesional injection of the fibrin glue, so intralesional bleomycin is also being tried. So 1 international unit of bleomycin, 1 ml, and lignocaine in the ratio of 4:1 that has been reported. Another agent is pingainamycin, which it belongs to the bleomycin family, and it was initially discovered in the Pingyang country of China, from where it has got its name. Some methods have used oral sildenafil. So the proposed mechanism, it causes smooth muscle relaxation. So sclerotherapy with sodium tetradecyl sulfate, that is still considered as a management option. So coming to the second category, we have orbital varices. These are congenital vascular venous malformations. They are very thin walled, they are distensible veins. They communicate with the systemic venous circulation. So here it is an intermittent and positional proptosis, and that increases on Valsalva. So that is the characteristic feature. So MRI with Valsalva, there will be enlargement of this venous channels. So observation, if it is asymptomatic, or sclerotherapy or surgery only for vision threatening cases. Now this shows the pre-contrast with the resting, and then after Valsalva, the image has been taken. Now the third category is the caroticocavernous fistula, or the high flow ones. So these are abnormal vascular communications and they lead to rapidly progressive orbital symptoms and signs. They have related ocular complications of CCF. That is because of your vascular occlusion and optic nerve compression. It can be a direct or indirect. So the majority of the direct CCF, they had traumatic etiology in 88% cases, whereas in indirect, it was because of hypertension and hyperlipidemia. So the classic findings, it is a dilated superior ophthalmic vein and a cavernous sinus enlargement when we suspect CCF. Now coming to the tumors of the neural origin, there are two, mainly we are dealing with two kinds of tumors, the optic nerve glioma versus the meningioma. So how do we differentiate these two? So they are both tumors that affect the optic nerve, but they have distinct characteristics. Both cause progressive visual loss, but if you're looking at the age and imaging, then they are the key differentiators. So when we are dealing with optic nerve glioma, in MRI, we can see the fusiform enlargement of the optic nerve. The optic nerve itself has swollen and it has caused the fusiform enlargement. The stereotypical, the kinking of the nerve, that is characteristic feature of glioma. In histopathology, we can see the pilocytic astrocytoma cells with, that impart a fibrillar appearance and also Rosenthal fibers. When we see cases of optic nerves with meningioma, that the tram track sign, that is characteristic feature. Here nothing happens to the nerve as say, but the sheaths, they are enhanced and we can see the enhanced sheath with the central non-enhancing nerve, and that is giving the sign of tram track. In histopathology, we have a large ill-defined cells with abundant cytoplasm. Numerous holes are found by several flattened cells wrapped around a large round cell. Semoma bodies sometimes occur within the holes. Now, these are some of the key differentiators which we need to know. Talking about the origin, in gliomas, it is basically from the glial cells. It affects the children and the young adults. It's often associated with neurofibroma type 1. But in meningioma, it originates from the meninges, which are the protective covering of the nerve. It affects the adults, particularly middle-aged females. It's generally a slow-growing tumor. Coming to the clinical presentation, gliomas, their common symptoms are visual loss, proptosis, and optic disc pallor. It may also cause a gradual decline in vision, but in meningioma, it has progressive visual loss, diplopia, and optic disc swelling. So imaging, as I have already discussed, the fusiform shape is characteristic of optic nerve glioma, while time track sign is characteristic of meningioma. Now coming to treatment, in cases of glioma, it can be watchful waiting if it is asymptomatic, but in more severe cases, surgical resection may be required. In meningioma, it includes, the treatment basically includes radiotherapy. So this is like one look, we can see that if it is a child with a fusiform nerve, then we are dealing with glioma. If it's an adult female with tram track appearance, then it is a meningioma. So the treatment also differs, and that's why it is very important to understand what we are dealing with exactly. Then coming to the tumors of lymphoid origin, we have orbital lymphoma. It is a very common orbital malignancy in the elderly. It is usually painless and causes painless progressive proptosis. Vision is preserved till late. The reactive lymphoid hyperplasia and slow growth lymphomas, they grow slow expansion over a period of months to years. But if it is a high-grade malignant lymphomas, then we have bony erosion. So in imaging, the characteristic feature is the homogeneous mass that molds around the structures without any bony destruction. So the key clues are molds around muscles and vessels, no bony destruction despite it being a malignancy. Biopsy is mandatory before treatment. Radiotherapy gives excellent control. And a newer advances is rituximab, which is being tried against the B-specific CD20. This has recently gained popularity. Now, considering tumors of the mesenchymal origin, we have rhabdomyosarcoma, and why it matters most. It is the commonest malignant orbital tumor in children. It arises from undifferentiated pluripotential mesenchymal elements. It has got a rapid onset, and that's why it becomes an oncology emergency. We see a mass in the supranasal quadrant of the orbit usually, so the workup is done on an urgent basis. CT and MRI help us to locate and see the extent of the tumor. The cervical and the preauricular lymph nodes, they need to be palpated to rule out any regional metastasis. So if it will show ill-defined aggressive mass with or without a bony destruction. So these are the red flags of rhabdomyosarcoma. If it is a child with acute proptosis, it is not always cellulitis. Pain, edema, and restricted movements are seen. Urgent biopsy and chemoradiotherapy. Now, to distinguish between a rhabdomyosarcoma and a lymphoma, the age, child, if we are dealing with child, then we are thinking about rhabdomyosarcoma. Well, if it is elderly, it is a lymphoma. If it is acute onset, if it is ill-defined or infiltrative, and the bone may be destroyed, then we are dealing with rhabdomyosarcoma. Well, if the bone is preserved, on MRI we are seeing the molding, and it is insidious onset, then we are dealing with lymphomas. Now, another tumor is fibrous dysplasia. It is a benign developmental disorder of the bone. It may involve a single reason or it may be polyostotic. So we can on CT, we can see hyperostotic bone, and in MRI lack of dural enhancements. So if it is associated with cutaneous pigmentation and endocrine disorder, then we are dealing with Albright syndrome. So the treatment is resection or debulking if there is disfigurement or visual loss due to stricture of the optic canal. Now, next is the lacrimal gland tumors. So this was a classification given by Rose and Wright, which help us to distinguish between the benign and malignant. So it takes into account many clinical as well as radiological characteristics, like the duration of acute symptoms, persistent pain, and sensory loss. Radiologically also, whether it is well-defined round or oval mass, molding of mass to globe, or along the lateral orbital wall, tumor calcification, invasion of bone, and duration of symptoms. Pleomorphic adenoma is the most common epithelial tumor of lacrimal gland. It occurs during the 4th to 5th decade. Males are more commonly affected. Progressive painless downward inward displacement of the globe. A firm lobular mass is palpated in the superolateral orbital rim. Imaging, we can see the expansion of lacrimal fossa. In cases of adenoid cystic carcinoma, it is the most common malignant tumor of lacrimal gland presenting in mid-teens. It causes pain because of perineural invasion and bony destruction. Rapid course, usually less than 1 year. It extends up to posterior orbit because of the ability to infiltrate and lack of encapsulation. Radiotherapy and chemotherapy work. Now coming to the next category, metastatic orbital tumors, they are rapidly progressive in the elderly population. They may be the first sign of systemic malignancy. The primary sites being breast, lung, and prostate. So in imaging, we can see a ill-defined infiltrative lesion with rapid progression. So how do we differentiate between metastasis and lymphoma, as both are in the elderly? So if the onset is rapid and if pain is common, and if it is infiltrative and the bone is getting destroyed, we suspect metastasis. Whereas in lymphomas, the onset would be slow, the pain would be rare, and we will see molding, and there is usually no bone loss. Now coming to the principles of management of these tumors, broadly it can be observation for small benign lesions, biopsy when you have an uncertain diagnosis, radiotherapy or chemotherapy when indicated, and always involve a multidisciplinary team. So small benign asymptomatic lesions, they can be observed. We go ahead with the surgery after diagnostic biopsy or complete excision, and it is indicated in cases of progressive proptosis, visual impairment, malignancy. Radiotherapy in cases of residual or recurrent tumors, and chemotherapy in cases of rhabdomyosarcoma and metastasis. So these are some of the factors which influence management, like the age of the patient, the site and extent of the tumor, the histopathology, the visual function, and the systemic status of the patient. Now, there are various surgical approaches in orbital tumors. Anterior orbitotomy, where the approach is through transconjunctival or transcutaneous. It is for well-defined intracorneal tumors located just behind the globe, like dermoid cyst or cavernous hemangioma, which is located anteriorly. So here the risk of enophthalmos and fat herniation is less. Lateral orbitotomy, where the lateral orbital wall is being removed in cases of extracorneal tumors or intracorneal tumors, like the cavernous hemangioma. Then medial orbital orbitotomy for transcaruncular or endoscopic endonatural approach when we are dealing with medial orbital and apical lesions. So these are some newer modalities in management of orbital tumors. Endoscopic techniques, these are gradually gaining a popularity because of their less invasiveness and more access to medial orbital and apical lesions. Then stereotactic radiosurgery, because of its high precision of radiation delivery and targeted molecular-based treatment targeting specific pathways. So to summarize, accurate localization and imaging are key for narrowing the diagnosis. Histopathology remains the gold standard for definitive tumor typing. Timely individualized management using a multidisciplinary approach, it improves the visual and systemic outcomes. So these are the take-home message. Age and localization of the mass to be kept in mind. Optic nerve status to be checked on every visit. Investigations to be tailored according to the differentials. Not all tumors require surgery, and always have a multidisciplinary approach. So these are my references. Thank you.
Thank you, Dr. Swadhishree, ma'am, for explaining this elaborate topic very, it is very difficult to explain on all of the orbital tumors in such a short time, but you have summarized it very well. So I have two questions. One is, ma'am, can you tell me your investigation of choice in suspected cases of keratocavernous fistula? And the second question is, in pediatric acute onset proptosis in pediatric age group, so is there any clinical clues to differentiate between the neoplastic and non-neoplastic etiologies?
So pediatric, like mostly we are dealing with, if it is a rhabdomyosarcoma, we are basically, it would be a very rapid onset and it would be painful. So then we should suspect rhabdomyosarcoma. And basically between the CT and MRI, when we are, we have already discussed that, I guess. So we, if we have this bony lesion, CT is always preferred, whereas MRI, it would help us to give an idea of the soft tissue lesions.
Ma'am, just in case of keratocavernous fistulas.
Yeah, so we would go ahead with the MRI investigations.
Okay.
Thank you, Dr. Swati. That was a wonderful talk. About that AML case, even Dr. Sonam showed a case with a child with fever with proptosis, acute onset proptosis, and then a peripheral blood smear showed acute myeloid leukemia. So for any childhood proptosis, pediatric proptosis, do you do a PBS first or do you do incisional biopsy?
We can go ahead with an imaging to help us first understand what the pathology is, and then maybe go ahead with the treatment.
Okay, sure. Any comments from the expert panel, sir?
Yeah, excellent talk by Dr. Swati. Thank you, madam. Very elaborately covered everything. And regarding your question, in pediatric proptosis, especially sudden onset, you have to be very careful because the chances of them having a malignancy is very much there. So, like you said, it's very important to do a peripheral blood smear because all that leukemias and all that are not at all uncommon, especially with acute sudden onset. They have the sort of periocular ecchymosis and all that. You have to be very careful. They could have be associated renal carcinomas and Wilms tumor. All that is not at all uncommon. But if it's a long-standing one and gradually or slowly progressing, all that, then it's not that ominous as acute proptosis. Also, you should have in mind lymphangiomas, hemangiolymphangiomas, sudden bleed in the lymphangioma, especially after an episode of a respiratory infection. They can also have acute bleed. So, I mean, acute proptosis. They can have a lymphangioma which is quiescent. Then, following a respiratory infection, they can have a bleed in a pre-existing lymphangioma which can present with a sudden onset proptosis. So, again, proper history taking, examination of the old photographs, with the imaging, you put everything together, you can actually come to a diagnosis and treat appropriately. I think she's covered almost everything. Again, metastasis, again, you should not overlook, especially in the elder age group, whether it's a female or a male, especially females, if it's a tight orbit, you have to rule out breast carcinoma is very important. But sometimes in breast cancer metastasis, they actually don't have a proptosis. Actually, the eye can go in. They can have they're all fibrosing metastasis. So the eye can actually go in. So if it's a female, again, you have to examine the breast examination is mandatory. And males, again, lung carcinomas, prostate, especially elderly people, all that you should keep in mind, whether it could be a secondary.
Yes, thank you, sir. Comments from Dr. Dayakar, sir?
Thank you. Dr. Swati, you covered very well. So, like, it's a vast topic and you're extensively covered. If you added some more photos, it will be much more better. But coming to the question, like, for a keratodermatous fistula, like, what I will do is, like, clinically, I diagnose a keratodermatous fistula and then arrange a CT. Along with the CT, I will write specifically for look for a enlarged superior ophthalmic vein. Because I'm not going to burden on the patient of the MRI, MRV, or MRA. By doing that, I'm not going to do anything more. So once I confirm the enlarged superior ophthalmic vein, Sonam has beautifully shown the pictures. So once it confirms there is an enlarged superior ophthalmic vein, I will refer the patient to the interventional neuroradiologist. So they will coil the thing, and then the patient will come back to me. I'll see them, follow it up. So that is my investigation of choice. The second, the pediatric trauma or pediatric cellulitis. All the patients with the pediatric people will come with some trivial injury. They'll come with the mother brings the bed, child has fallen from the bed while playing, child has fallen. So in that case, all the cases, like first I will give admit and then start a imaging. CT is the imaging of choice. Sometimes the ethmoid sinusitis also presents as orbital cellulitis. Rule out orbital cellulitis. And then if it is in the CT imaging, we are not able to conclude, then I'll go for a peripheral smear. So, but all the cases, I will not go for a peripheral smear. Okay. So otherwise, Swati, you covered very well. All the topics you covered very well. Thank you.
Thank you, sir.
Dr. Kirti ma'am, Dr. Seema Das ma'am, any comments?
Yeah, hi. Very well covered topic. Very vast. Orbital tumors and such is a very, very vast topic. It not just includes malignant, but even the benign lesions. So one of the main important clinching factors many a time is imaging. In imaging, you can actually differentiate what kind of tumor and based on location. So certain tumors have a probability that they'll be more common in a particular area, like say LCH is generally often seen in the supratemporal aspect. Okay. Now, rhabdomyosarcoma it can occur in any other quadrant. Now, gliomas, meningiomas are going to be intraconal. Pleomorphic adenoma, lacrimal gland neoplasms again will be supratemporal. So that way you can help to differentiate. And plus, on imaging, you have certain characteristic features like capillary hemangioma will have flow voids. Okay, and whereas lymphangioma will have fluid levels. So that's a differentiating factor in capillary hemangioma and lymphangioma, because in one the treatment is going to be oral propranolol, the other the treatment of choice is going to be intralesional sclerotherapy. So imaging in many a time helps you diagnose and treat. If you know that if a child is having a rapidly progressing lesion, it's important to differentiate, because sometimes a chloroma, LCH, everything will look very similar, but on imaging you'll be able to differentiate what is a chloroma, what is an LCH. And if it's an LCH, you can give some amount of intralesional steroid and that itself is going to be curative. Whereas you know that if it's going to be a rhabdomyosarcoma, you don't need to completely debulk. All you need is a biopsy sample to confirm your diagnosis and start the treatment. Gliomas are there in children. Very important to look for neurofibromatosis features in such children. Okay, and it's very important to document the visual acuity, but many times very small children you cannot see visual acuity, so VEP is very important to be done in such children. Treatment nowadays, you can do chemotherapy. Chemotherapy can help you cause a regression of the size of lesion, or at least stabilize the lesion and prevent further progression of the lesion in gliomas. In most cases, lymphomas in adults you had covered. Molding around the globe is a very clinching factor in your diagnosis, and always look for a Saman patch. Because if you have a Saman patch, you don't have to do an elaborate orbital biopsy. All you need to do is take a simple biopsy from the Saman patch, get your answer, and then a PET scan after that. And based on that, chemotherapy or radiotherapy for treatment of such patients. So it's important to put all the points together, but just by the clinical picture, you cannot go by it. You need to correlate to the imaging and then your histopathology. One more thing is, in children, never take the history for granted. Most parents will only give you a history of trauma, and that is why the tumors there was a worsening of proptosis. They'll always correlate it to the trauma, and that is why most people end up thinking that it is a orbital cellulitis. But actually, it would be some other history there which is hidden or missed, and the parents only look at the trauma history. So don't just go by that and start treating the patient with antibiotics. Image and make sure it is only a cellulitis and you're not missing out some kind of a tumor in a child before starting treatment in such children. That's it. Yeah.
Kirti ma'am, just my doubt actually. So there is a salmon patch lesion and the patient is having an orbital, deep component also. Should we take, deep biopsy as well? So because otherwise it can just come like a reactive lymphoid hyperplasia.
Usually it doesn't, because you can even see on imaging sometimes the deep component will be continuous with the salmon patch. You will see a continuity on imaging. And if you see such continuity on imaging, you can just take a biopsy from the salmon patch and you don't need to take from the orbital. Now see, a salmon patch biopsy can be taken under local anesthesia. Chance if it comes as a reactive, you can always take up the person under general anesthesia for the orbital biopsy. But if you clinch a diagnosis of a lymphoma from your salmon patch itself, then you don't have to do an unnecessarily elaborate surgery to confirm your diagnosis.
Okay, thank you so much. Any other comments?
Thank
Dr.
you.
Senthil, sir?
She has covered everything completely. That's elaborately covered. Even Dr. Kirti's comments are well taken.
Okay. So if there is no other comments, shall we move to the next topic? So that is on applied embryology and anatomy of the orbit by Dr. Aparna Singh. Over to you.
Very good afternoon to all of you. At the outset, I would like to thank the platform of GuruSangam for giving me this opportunity. And as I start my screen share, are my slides visible?
Yes, ma'am. It's visible and audible.
Thank you. I'm Dr. Aparna Singh, serving as Associate Professor in the Department of Ophthalmology at Maharaja Agharsen Medical College, that is in Agroha, Hisar, Haryana. I thank all the previous speakers for setting up the stage. I'll be talking on the applied embryology and anatomy of the orbit, and I only hope to do justice to such a vast topic in the short time that I have been allotted. I have a few disclosures to make. I'll be using a few common short forms which are commonly used in the ophthalmology literature, like the SR for the superior rectus or the ICP for the intracranial pressure. And I have, for most part of this presentation, I have used the atlas of Dutton's for the illustrations. I'm sorry, I'm not able to see my screen. Some glitch from my side. Can someone help me with that? I think my screen share is visible to all, but I am not able to see my slides. So what could have gone wrong? I think I'll stop the screen share and reshare again.
You can reshare your screen, Doctor. Yes.
Yeah, thank you. So let us warm up to the topic and come to the question of why at all we are discussing this topic. So why should we know the anatomy of any region, for that matter? If the residents would have been here, I would have conducted a small activity which we usually do call brainstorming. But since we don't have many of the live residents over here. So this would have set up the stage for the objectives. So whenever we are dealing with a topic, we should all have our own learning objectives. And the learning objectives of this session are, by the end of the session, the residents should be able to discuss the anatomy of the clinical importance of the orbit and the following headings. So I'm following this from the Dutton's Atlas itself. So we'll be starting with the cavernous sinus, then going on to the osteology, the extraocular muscles, the orbital nerves, arterial venous supply, and the orbital fat connective tissue, going on to the eyelids, the lacrimal system, and finally the radiographic correlations. So coming on to the cavernous sinus, it's a paired extradural sinus containing the plexus of thin-walled veins. It connects the intracranial cavity with the orbit, and this is a very popular diagram of the coronal section of the cavernous sinus, which every resident, I feel, should know and be able to reproduce in the exam. So having a look at it, the cavernous sinus is medially bound by the body of the sphenoid and the diaphragma sella, and laterally you have the dural wall. Anteriorly it goes into the superior orbital fissure, and posteriorly it is bound by the vitreous part of the temporal bone. The content of the cavernous sinus is the intracavernous part of the internal carotid artery, and abutting it is the sixth cranial nerve. Now the wall of the the cavernous sinus is important from superior to inferior. The lateral wall contains most of the cranial nerves which are going onto the orbit. That is the third cranial nerve, the fourth, and the fifth cranial nerve, the first division, and the second division.
Dr. Aparna, your voice is cracking a little bit.
Okay, I'm sorry. Should I go back again, or is it okay if I
We
continue?
can hear you. Yes, you can
Am
continue.
I audible?
Yes, you're audible.
Thank you. Yeah, so the cavernous sinus, it drains the venous blood from the face, and you have a dangerous area of the face which is being drained by the frontal vein, the superior ophthalmic vein, and also the inferior ophthalmic vein. Inferiorly, you have the pterygoid plexus. So all these are supposed to be mostly valveless veins, and an extra cranial pathology or infection can get drained and converted into an intracranial infection by way of these plexuses and tributaries to the cavernous sinus. Now, knowing the anatomy of this region is important so that you can differentiate between syndromes like the orbital apex syndrome and the cavernous sinus syndrome. So a good clinical examination would help you do that. In orbital apex syndrome, you'll have total ophthalmoplegia because of the involvement of the oculomotor, the trochlear, and the abducen nerve palsies. You can also have the involvement of the first division of the maxillary, the trigeminal nerve, which is the ophthalmic branch, and there could be proptosis, chemosis, and also involvement of the optic nerve. Whereas in a cavernous sinus syndrome, you would have all the features of the orbital apex syndrome along with Horner's syndrome, as the sympathetic chain gets involved here. And there could be also involvement of the second branch of the trigeminal nerve. Coming on to the osteology. Now, embryologically, the orbital bones are being formed around the developing optic cup and stalk, and they form the two orbital axes. They form an obtuse angle with each other, and as the embryo grows, the angle between the two orbital axes is reduced to 45 degrees at birth. Now, failure to do so would lead to hypertelorism, as is seen in this picture. Malposition and ossification of the orbital bones may result in shallow orbits and proptosis, as seen in this patient of Crouzon's disease. In the adults, the orbit is a pyramidal-shaped structure. Okay, I'm sorry. I have again made a mistake in some.
No worries, ma'am. We can reshare the screen.
Yeah. I think the screen is visible again.
Yes, it is.
Yes, ma'am. Yes.
Okay. So, in the adults, the volume of the orbit is around 25 cubic centimeters, and it's a pyramidal shaped structure with the apex at the back, and the base of the orbit is open anteriorly. It is formed with 4 walls, and the dimensions of the orbit are very variable, especially the depth. So caution must be exercised in the posterior orbital dissections. Now, coming on to the orbital rim, the superior medially, the orbital rim has a notch which is around 25 to 30 millimeters from the facial midline. So this acts as a guide for the protection of the supraorbital neurovascular bundle, which is exiting the orbit at this region. Inferiorly, the infraorbital foramen, which is transmitting the infraorbital neurovascular bundle, is located around 4 to 10 millimeters from the center of the inferior rim. So your dissections of the periorbita or the periosteum should not extend beyond the 4 mm mark below the inferior rim. Laterally, the orbital wall rim is the thickest. The frontozygomatic suture is a weak suture, and it generally gets separated in facial trauma. This is also a landmark for the anterior cranial fossa, which lies 5 to 15 millimeters above this level. Okay, I am not able to move my screen.
Could you click on your screen? It should start moving.
Okay, thank you. Coming on to the medial wall, the medial wall is formed by the maxillary, the lacrimal, ethmoid, and the sphenoid bones. The creation of the bony ostium during the DCR procedure is at the suture between the maxillary and the lacrimal bone, which is at the floor of the lacrimal fossa, as is seen in this picture. The lamina pepracia is a fragile bone, which is part of the ethmoid bone, and it is commonly fractured in trauma, and it is the area from which subperiosteal abscesses can form in ethmoidal sinusitis. The frontoethmoid suture marks the base of the anterior cranial fossa. So these are the landmarks on the medial wall. The floor of the orbit is formed by the maxillary, the zygomatic, and the palatine bone. It is the shortest of all the walls. It is thinnest medial to the infraorbital canal, contains infraorbital sulcus, separated from the lateral wall by the inferior orbital fissure, which connects the pterygopalatine and the infratemporal fossae to the orbit. So this is the commonest wall to be fractured in blunt trauma. It does not extend all the way up to the orbital apex, is what is to be remembered while dissecting the floor. The lateral wall is formed by the zygomatic, the greater wing of the sphenoid. It is the thickest of the walls, and its thinnest part is the zygomatico-sphenoid suture, which is seen here vertically. And this suture line is used to cut for the lateral orbital surgeries. The superior orbital fissure is at the junction of the lateral wall and the roof of the orbit, and this connects the cavernous sinus with the orbit. Coming on to the orbital roof, the orbital plate of the frontal bone and the lesser wing of the sphenoid are the bones which form the orbital roof. So, few features of the orbital roof. Medially, there is the trochlea. Laterally, there is a fossa for the lacrimal gland. The roof is very thin, and sometimes spontaneous dehiscence can be seen in the roof. The roof has the optic canal at the apex, which transmits the optic nerve and the ophthalmic artery from the middle cranial fossa to the intraconal space of the orbit. Now, deviations in the shape of the optic canal or its horizontal enlargement to more than 6.5 millimeters or asymmetry of more than 1 millimeters between the two optic canals at the orbital end can be considered pathological. Coming on to the extraocular muscles, the extraocular muscles, they are 4 recti and 2 obliques, and the LPS. So the function of the extraocular muscles is obviously the ocular motility and also the suspension of the globe in the orbit. Embryologically, if the LPS is incompletely separated from the superior rectus, there could be a superior rectus muscle weakness in cases of congenital ptosis. In adults, the extraocular muscles, they are specialized striated skeletal muscles with more of small fibers, greater vascularity, looser envelope of connective tissue, and with greater elastic fibers. There is this orbital and global layers of all the extraocular muscles except the LPS, which has been described. So let us look at the structure of the annulus of Zinn. It's a fibrotendinous ring at the orbital apex, which serves as the origin of the four recti muscles. And here is a picture diagrammatic representation of the ring. The contiguity of the superior rectus and the medial rectus with the optic nerve sheath at the apex causes painful ophthalmoplegia in retrobulbar optic neuritis. And the inflammation of the medial rectus and the inferior rectus in thyroid eye disease is the cause for compressive optic neuropathy at the apex. Muscles penetrate the tenon's capsule and bear numerous check ligaments which keep them from retracting into the orbit while operating on them. There is something called as the intermuscular septum, which is deficient posteriorly but more for optic stalk, which is developing from the prosencephalon. There is an embryonic fissure which develops on the ventral surface and it starts closing from proximal to distal, and at the optic cup, the center point closes first. So in case of the inability of or incomplete closure of this fissure happens, then there is something called as coloboma which develops, and the iris is the commonest structure to develop this coloboma. This is a picture showing iris coloboma. Myelination of the optic nerve begins at the optic chiasm and stops at lamina cribrosa at 1 month postpartum. And clinically, we can see myelinated nerve fibers on fundus examination if the myelination has not stopped at the lamina cribrosa. This should be differentiated from cotton wool spots. In the adults, the subarachnoid space around the optic nerve is continuous with the middle cranial fossa into the posterior sclera. So raised ICP leads to optic nerve compression and papilledema. That is why the fundus examination is so important in cases of sixth nerve palsies and other non-localizing signs of raised ICP. So coming on to the optic nerve, it has 4 anatomical portions. The intraocular is 1 mm long, and it is the part which exits from the lamina cribrosa. The lamina cribrosa, the pores are larger in the poles. So you have a wider neuroretinal rim, and the fibers coming at the poles are from the periphery of the retina. That is why early glaucomatous changes are seen at the poles. The combination of the myelination and meningeal sheath results in the enlargement of the optic nerve at the posterior globe. So malignancy closer to 1.5 to 2 mm to the optic disc cannot be treated with an episcleral plaque. The second part of the optic nerve is the intraorbital part, which is 25 to 30 millimeters long. It is S-shaped curve, and the redundancy of the optic nerve at in this area allows for the ocular motility without stretching of the nerve. So surrounded by all the 3 meninges, there is an increase in the diameter of the optic nerve as it is leaving the globe. So this increase in the diameter is further increased because of the raised ICP, and this allows for a safe optic nerve sheath fenestration procedure when needed. Intracanalically, the optic nerve is measuring 5 to 6 millimeters, and there is fusion of dura to the periosteum. It is vulnerable to compression and contusion injuries in this area. Intracranial part consists of 10 mm length of the optic nerve. There's close proximity of the optic nerve to the vascular structures over here. So compression from aneurysms of the surrounding vessels can happen. Coming on to the optic chiasma, it lies above the body of the sphenoid, and it has variable anterior-posterior position. So depending upon its position, there can be variation in field effects due to tumors in this region. There is a basal cistern which is separating the chiasm from the diaphragmatic maxilla, which is measuring around 10 mm. So the expanding lesions of the pituitary might be huge before they manifest or cause compression on the chiasm. So optic nerve health can be judged by the optic nerve function tests like the pupillary light reflex and the visual field analysis, which can determine the site of the pathology. coming on to the oculomotor nerve. So it has somatic fibers to the medial rectus inferior and rectus, the inferior oblique, and the LPS, and parasympathetic fibers to intrinsic muscles of the eye, and also sensory neurons from the proprioceptive receptors in the extraocular muscle it innervates. So this is just a depiction of the orbital apex from where all the ocular motor nerves are entering, and also a diagram to represent the nerve nuclei. Coming on to the oculomotor per se, it starts from the midbrain nucleus and exits the interpeduncular fossa, travels in the subarachnoid cistern along the lower border of the tegmentum tentorium, and then it enters the cavernous sinus posteriorly in the lateral wall of the cavernous sinus, lateral to the posterior clinoid process, and it enters the superior orbital fissure into the orbit inside the annulus of Zen in the oculomotor foramen. Here it can divide into the superior and inferior division, or the division can happen in the anterior part of the cavernous sinus. So what are the clinical aspects of this anatomy of the oculomotor nerve? So the nerve, as it exits or travels in the subarachnoid space, it is very close to the tentorium cerebelli, and here it can get compressed by uncal herniation or raised ICPs, and that could cause ipsilateral ophthalmoplegia and Hutchinson pupil. So this picture is depicting right-sided lesion wherein the pupil is constricted in stage 1, and stage 2 it becomes dilated, non-reacting, and stage 3 there can be bilateral fixed dilated pupil. In the intracavernous part, or in the cavernous sinus wall, the pupillomotor fibers maintain supromedial position, and this is responsible for the susceptibility to aneurysms of the posterior communicating artery, which can cause a compressive lesion. So anteriorly in the cavernous sinus, it receives sympathetic fibers from the superior cervical ganglion via the ICA plexus, and it can divide into the superior and inferior branches in the anterior portion of the cavernous sinus. Now coming on to the intraorbital part of the oculomotor nerve, it enters the orbit through the oculomotor foramen. It divides into smaller superior and an larger inferior branch. The superior division gives off branches to the superior rectus and the LPS. The rest of the muscles are supplied by the inferior division. The branch to the inferior oblique, as is seen in this diagram also, gives off a branch to the ciliary ganglion, the preganglionic parasympathetic fibers. So localizing the lesion would be easy if we know the anatomy. If it's a nuclear lesion, unilateral third nerve palsy with contralateral superior rectus weakness would be seen. And if it is a cavernous sinus lesion, you would have other extraocular muscle palsies along with the maxillary division of the trigeminal nerve causing pain. If it's an orbital lesion, then you can have total ophthalmoplegia with proptosis. And in ischemic conditions like diabetes mellitus or hypertension, there is a pupil sparing oculomotor palsy due to the pupillomotor fibers receiving more collateral blood supply than the main trunk. However, this is not a rule. So let us look at what is happening at the level of the ciliary ganglion. The ciliary ganglion is located in near the orbital apex, lateral to the optic nerve and medial to the lateral rectus. So between the optic nerve and the lateral rectus, and it is a parasympathetic synaptic ganglion associated with the ophthalmic division of the trigeminal nerve and inferior division of the oculomotor nerve. So there are sensory fibers from the globe via the short posterior ciliary nerves, which are entering the ciliary ganglion. There are parasympathetic motor route from the inferior division of the oculomotor nerve, which synapses with the inside the ganglion, and the short posterior ciliary nerve. There will be motor supply to the iris sphincter and the ciliary body, and there are sympathetic fibers from the carotid or the ophthalmic artery plexus, which is also entering the ciliary ganglion without any synapse. So postganglionic parasympathetic fiber injury may cause isolated internal ophthalmoplegia known as the tonic pupil. And for retrobulbar anesthesia to be effective, the drug has to be placed in the vicinity of the ciliary ganglion and the extraocular motor nerves. So this is a diagrammatic representation of the location of the ciliary ganglion. Coming on to the trochlear nerve, the nucleus is at the level of the inferior colliculus. It is the only crossed cranial nerve to exit from the dorsal midbrain. It runs inferiorly and lateral to the oculomotor nerve in the cavernous sinus wall. It enters the orbit through the superior orbital fissure superior to the annulus of Zinn. So obviously it is going to supply structures outside the cone, crosses over to the over the origin of the superior rectus to pierce at multiple branches at the superolateral surface of the superior oblique. So it has a long intraorbital course, which is mostly adjacent to the orbital wall. So it has a long intracranial course, so it makes it prone to injury from intracranial lesions. And the intraorbital part, the nerve lies close to the bony wall, so it makes it vulnerable to blunt head trauma, unilateral or bilateral superior oblique palsies. Coming on to the next nerve, which is the abducens nerve. It is one of the last of the motor nerves in embryogenesis. The nucleus is in the pons. Both the adjacent nerves ascend on the clivus in close proximity to each other. So failure of the nerve to develop may result in aberrant innervation of the lateral rectus by oculomotor nerve, which is known as the Duane syndrome. The basilar artery aneurysm or chordomas can cause bilateral abducens nerve palsy, as both the nerves are running in close proximity in this area. And as the nerve bends over the petrous apex beneath the ligament of petroclinoid, there is change of direction abruptly. So this makes it vulnerable to compressive lesions, chronic mastoiditis, and head trauma. The nerve next travels lateral to the intracavernous carotid artery in the body of the cavernous sinus. So this is the first nerve to be affected by an intracavernous carotid artery aneurysm. Oculosympathetic fibers run with the abducens nerve for a short distance. So sixth nerve palsy with ipsilateral Horner syndrome can be localized to the cavernous sinus. So look at the intraorbital part of the abducens nerve. It enters through the superior orbital fissure and the oculomotor foramen of the annulus of Zinn. It ramifies into 2 to 7 branches before penetrating the conal surface of the lateral rectus muscle. So here is a composite view of the intraorbital oculomotor nerves. And this is an eidetic image taken from Dr. Dutton's lecture. This can be committed to memory if gone through properly. Next is the sensory nerve, that is the trigeminal nerve. It has a small motor and large sensory component. The ophthalmic division, which is the major sensory input it receives the major sensory input from the lids and the orbit. The next is the maxillary division, which supplies or gets information, the sensory input from the small compartment from the lower lid. This is how the trigeminal nerve ophthalmic division and the maxillary division, they are placed in the orbit. And the first branch of the trigeminal artery, it is in the lateral wall of the cavernous sinus below the trochlear nerve. As it enters the orbit, it divides into the lacrimal, frontal, and nasociliary nerves. That is before the superior ophthalmic orbital fissure. The lacrimal nerve is the smallest branch, as you can see in the picture. It is going laterally. And it enters outside the annulus. It is joined by communicating branches from the zygomaticotemporal nerve of the second branch of the trigeminal nerve. It ends in the conjunctiva and skin of the lateral upper eyelid. Next branch is the frontal nerve. It is the largest branch of the ophthalmic division, enters outside the annulus. It branches into the supratrochlear and the supraorbital nerves, as is seen in the picture. The supratrochlear nerve gives a communicating branch to the infratrochlear branch of the nasociliary nerve, since it carries sensations from the lower portion of the forehead, skin, conjunctiva, medial side of 1/3 of the upper eyelid. The next is the supraorbital nerve. It carries sensations from the skin and conjunctiva of the central 2/3 of the upper eyelid, skin of the forehead till the lambdoidal suture. So this information is important. The surgical dissections involving the forehead, like direct brow lifts, should avoid excision of the frontalis muscle fibers in the medial eyebrow where these nerves are located. And this picture is giving us the dermatomal distribution and of the sensory input of the various branches of the trigeminal nerve. Next is the nasociliary nerve, which is a small sensory, it gives a small sensory branch to the ciliary ganglion, and 2 to 3 long ciliary nerves which pierce the sclera adjacent to the optic nerve. And it gives off the infratrochlear nerve, which is the terminal branch. The infratrochlear nerve innervates medial eyelids, medial conjunctival caruncle, and lacrimal sac. And it is also blocked during external DCR procedure. The maxillary division is the second division of the trigeminal nerve. It gives it in the orbit, it travels as the infraorbital nerve through the inferior orbital fissure and exits through the infraorbital foramen. So it gives off the palpebral branch to the lower eyelid and skin and the conjunctiva. The zygomatic nerve also enters the orbit through the inferior orbital fissure, and it divides into the zygomaticotemporal and zygomaticofacial nerves before entering the groove. Trauma to the infraorbital nerve causes paresthesia in the skin of the lower lid, cheek, and gum before and up the incisor and the canine teeth areas. So this is a diagrammatic representation of all the sensory branches of the trigeminal nerve, and if committed to memory, it would be easy for us to give the various nerve blocks that have been described on the right hand side. Clinical correlations of the trigeminal nerve, a condition known as herpes zoster ophthalmicus. It targets the most commonly the ophthalmic division of the trigeminal nerve, and it has a unique dermatomal distribution. So it is a spotter in itself. The next is the oculocardiac reflex, the arc of which the afferent is formed by the ophthalmic division of the trigeminal nerve, and it can be prevented but not completely avoided by retrobulbar anesthesia. Another reflex is the oculorespiratory reflex, which can be completely blocked by retrobulbar anesthesia. Now, certain lesions of the cavernous sinus, if clinically examined, could tell us the region of the cavernous sinus which is involved, like lesions in the posterior cavernous sinus would cause ophthalmoplegia with ipsilateral facial anesthesia and loss of mastication. Lesions at the center would spare the third division, and lesions in the anterior cavernous sinus would spare both the second and the third division. So we'll not be looking at the facial nerve. Going on straight away to the autonomic innervation of the orbit. So autonomic consists of the sympathetic and the parasympathetic. The sympathetic gives off homeostasis, helps in homeostasis because of the vasoconstriction and dilatation of the uveal vessels. And something called as the Horner's syndrome affects the sympathetic system. So the ipsilateral destruction of 3-neuron oculosympathetic innervation to the head and the neck is what is the Horner's syndrome. So we very well know that the approach of deciphering whether it is a first order neuron or the second or the third order neuron which is damaged in this syndrome. Then there's the parasympathetic system, which has mostly the secretomotor function. The preganglionic fibers from the superior salivatory nucleus of the facial nerve, they pass through the geniculate ganglion through the greater petrosal nerve, which joins the second part of the trigeminal nerves. The fibers synapse in the pterygopalatine ganglion. Postganglionic fibers via the zygomaticotemporal nerve reach the lacrimal and the meibomian glands. Coming on to the arterial supply. The ophthalmic artery is a major blood supply to the orbit, and it is the first branch of the internal carotid artery. It is vulnerable to compression due to raised ICP in the optic canal. So the ophthalmic artery crosses the optic nerve mostly superiorly and travels anteriorly. It has a various branching pattern in the orbit. orbit. So looking at the branches of the ophthalmic artery, there are the ocular branches, which are the central retinal artery, the posterior ciliary artery, some small collaterals to the optic nerve. And you have the orbital branches, the lacrimal artery, the branches to the extraocular muscles, orbital fat and vessels to the periosteum. You have the extraorbital branches, the ethmoidal, the palpebral, supraorbital, terminal branches like the supratrochlear and the dorsal nasal, and you have your dural branches. So there are arcades in the eyelid, which consists of vast anastomotic network between the internal carotid and the external carotid arteries. So major two arterial arcades are the marginal arcade, which is located 2 to 3 millimeters above the lid margin, and a peripheral arcade, which is located at the superior border of the tarsus behind the LPS. So understanding of localization of these arcades during surgery is important. Visualization of these vessels during eyelid surgery indicates disinsertion, can indicate disinsertion of the aponeurosis. There are various anastomotic connections between the internal carotid artery and the external carotid artery, and few have been mentioned over here. So this prevents orbital ischemia. Venous and lymphatic systems as the next topic. There's high degree of individual variation in the venous system. So unlike arterial system, the veins in the orbit maintain an intimate relationship with the complex facial systems of the orbit. This prevents excessive stretching or collapse of the venous walls by the ocular motility. Veins become more vulnerable to orbital fibrosis as in thyroid eye disease. The veins do not follow a course parallel to the arteries except the central retinal, the lacrimal, and the ethmoidal veins. So this is the venous system in short. The superior ophthalmic vein is the largest vein in the orbit, and it is carrying the venous blood from the superior supraorbital vein, the supratrochlear vein, and there are multiple vortex veins which are present more medially than laterally. The superior orbital vein leaves the orbit through the superior orbital fissure superior to the annulus of Zinn. It enters the anterior cavernous sinus. There is increased venous pressure. If there is increased venous pressure within the sinus, that results in dilatation of the superior ophthalmic vein, as we have seen few cases of CCF in the previous discussions. Orbital varices and AV malformations and shunts can also form in the orbits. The lymphatic system in a gist is given over here. The superior lid, the lateral 2/3 and the inferior lid lateral 1/3, and the central or the lateral half of the conjunctiva drains into the preauricular lymph node as is depicted in the diagram. The rest of it drains into the submandibular node. Coming on to the orbital fat and connective tissue. This provides compartmentalization in support of the orbital structures. The orbital fat can be divided into intraconal, extraconal, and anterior peribulbar fat. The Denon's capsule, as shown by the blue color in this diagram, it extends from the 2 millimeters behind the limbus to 9 to 10 millimeters behind. It is important not to incise the tenons beyond this limit to avoid exposure of the orbital fat. Then there are anterior suspensory systems, which include the check ligaments, the Lockwood, and the capsulopalpebral fascia which link the lower eyelid with the downward retractors. And there is also Whitnall's ligament superiorly. We have the intermuscular septum. The rectus muscle pulley systems have been defined, and there is a posterior suspensory system to prevent slippage of extraocular muscles during extreme excursions of the globe. So surgical manipulation might distort the position of these structures, and hence the extraocular muscle kinetics can be hampered. Coming on to the eyelids and the anterior orbit, something called as the orbital septum, which separates the orbit from the eyelids. And looking at the skin or the eyelids as such, the scalp, which is the skin, the subcutaneous tissue, the musculoaponeurotic layer, loose areolar tissue, and deep fascia and periosteum. So elevation of flaps in the forehead usually develop in the, you have to do it in the subgaleal areolar tissue plane. Frontalis muscle elevates the brow, which in turn may elevate the upper lid. So hence you have to block the action of the frontalis during the ptosis measurements. The lateral brow lacks elevator, hence age-related ptosis can be present. Eyelids develop from the frontonasal and maxillary processes. The fused eyelid begins to separate along their anterior margin. So failure to do so can result in ankyloblepharon, as is seen in this clinical picture. The orbital septum should never be sutured. So this is a picture depicting the orbital septum. I remember there was a recent question for the postgraduates on the structures penetrating the orbital septum. The preopeneurotic fat pockets are 2 in the superior lid and 3 in the inferior lid. So position of these pockets is important to note because they are important landmarks for during ptosis or levator muscle surgeries. There is something called a superior facial musculoeponeurotic system. I'm sorry for the spelling. Superficial musculoeponeurotic system, which helps distribute forces of the facial muscles to the dermis. Coming on to the lacrimal system, the lacrimal gland and the lacrimal drainage system. So the lacrimal gland is located in the superotemporal fossa. It is divided into the orbital and palpebral lobes by the lateral horn of the LPS aponeurosis. Ducts from the orbital lobe pass through the palpebral lobe to open in the conjunctival fornix. So surgical dissections in this area can cause scarring and dry eye disease. Now looking at the lacrimal drainage system, this is the lacrimal pump mechanism which has been shown. So the punctum, the canaliculi, the sac, and then the nasolacrimal duct. So with each blink, the canaliculi shrink and there is a positive pressure which is created, which pumps the fluid collected in the lacrimal sac into the nasolacrimal duct. And as the lids open, there is a negative suction pressure which is created to suck the tear film into the canaliculi. So it goes in a cycle. Lastly, but not leastly, you have the radiographic correlations. I always tell my residents to read the CT MRI on their own before looking at the report generated by the radiologist. So how to go about it? Let us just compare the CT and the MRI techniques. So CT imaging is the procedure of choice for evaluating orbital trauma. The slice thickness is 1 mm to 1.5 mm. The orbital CT should include both axial and coronal planes routinely. Contrast enhancement, though less useful than for brain studies due to lack of blood orbital barrier, it should be included in all orbital scans. And in suspected bony involvement, you should use bone windows. In magnetic resonance imaging, it is superior for tissue differentiation. The imaging procedure of choice for non-traumatic pathology and optic pathways, the soft tissue visualization at the orbital apex, optic canal, and cavernous sinus is much better. T1 and T2 weighted signals, they provide contrast differentiation between adjacent tissues. Small surface coil technology, it improves signal to noise ratio. Now we have fat signal suppression techniques which improve visualization of the orbital lesions. Dynamic MRI avoids the risk of iodinated contrast agent, and then you used gadolinium, which shortens the T1 relaxation time and increases the signal intensity. So here is an example of the axial section through the inferior orbit. The plane of the axial scan has been shown and a diagrammatic representation is given below. So let us look at what is being seen in the scan. The above is the CT scan and below is the MRI scan. So in CT, you can see the bones very well and the soft tissue is a little fuzzy. From anterior to posterior, you have the nasal bone and you can also see the nasolacrimal canal. And then you have posteriorly in the same line, you have the maxillary sinus. The air appears black on CT. And inside the orbit, what you can see is the globe, and you can also see the inferior rectus and laterally, the lateral wall of the orbit, you can see the zygomatic bone. So this is what can be made out. And inferiorly, you have the MRI scan, wherein you see more of the fat, the intraorbital fat is seen. And the rest of the structures we have discussed in the CT scan. Okay, the coronal section, this is an example of the coronal section, and the plane of the coronal scan has been shown, and we have a CT cut. So what all is seen over here? It is from the posterior orbit. So what we are seeing are the extraocular muscle, the recti, in the periphery, and we are also seeing the inferior orbital fissure in the extreme left, right lower corner, and the center we are seeing the optic nerve. So we should, if we start looking at the normal, we would be able to pick up the abnormal. So these were my references, and our patients are our best books. So for residents, I would say that keep reading and keep examining clinically and come back and read again. So that is how the learning goes. And this is one book which I would recommend for all to read. Thank you very much for your patient listening.
Thank you, ma'am. That is a very well explained, very elaborately, and as well clinically, as well radiologically correlated also. So that book is also my suggestion as well. The pictures are very, very beautiful. So this is a high yielding topic for the exams as well. And this is a cornerstone, the embryology and the anatomy, on which we have to build our further knowledge. So I should suggest, I should say that we have to know the pictures. We have to draw in our books as well. Keep a book for the anatomy. This will help you for the exams as well. Okay. So any comments, Dr. Seema Das ma'am? Dr. Dayakar sir?
Yes, very well covered, madam. It's not easy to cover from the full anatomy, embryology, everything very well covered. Extensively covered. It's very volatile and it's difficult to explain, but you covered very well in 30 minutes, and it's amazing. Few points I would like to add. I'm quoting an article from the from American Academy of Ophthalmology, Richard Cho and Alon Kahana. They published an article. They're saying the most of the orbit develops from the neuroectodermal cells. See, in general, orbital anatomy develops from the surface ectoderm, neuroectoderm, neural crest cells, and the mesoderm. See, the majority of our interest is in the neural crest cells. These crest cells migration depends on the sensors, their complement factor 3, and the VEGF, and fibroblast growth factor. These are the factors which are influencing the migration of the neural crest cell from the crown to trough, from the top to bottom. See, all these completes in 8 to 12 weeks time. So when there is the interruption in the neural crest cell migration, so what happens is these anomalies will come, like a golden horse syndrome. So where there is a microhemifacial developmental abnormalities, like a limbal dermoid, preauricular tags, all that will be there. Similarly, like a Treacher-Collins syndrome, like a mandibulofacial dystocias, so that will be there. Similarly, Sturge-Weber syndrome. These are the syndromes which covers when there is a neural crest cell developmental abnormalities are there. And the second is similarly, neural crest cells develops into the abdomen also. When there is abnormality there is a melanomas, Merkel cell tumors, or neuroblastomas. And the child comes with the swelling, the proptosis, and in the abdominal, you put a hand on the abdomen, you can see there is a swelling in the renal area. So these are the major things I wanted to add. Otherwise, you covered very well, madam. Thank you.
Dr. Senthil sir?
Yeah, congratulations, Dr. Aparna. You covered the whole topic very beautifully, from the embryology and very detailed about the arterial, venous, lymphatic, and very nicely you covered. And from my point of view, just 2 points which I'd like to make is like what she said, the lymphatic drainage. So in case of any lid tumors or anything, it's very important for us to palpate the nodes, the preauricular, submandibular nodes, and see if there's any enlargement of the lymph nodes. Because if there's enlargement, that means there could be a spread. That is one thing. The other important point which she made was how you should not suture the orbital septum. That's very important, especially when you do ptosis surgeries and all. We open up or even if it's a case of a lid injury, which a general ophthalmologist is required to suture, you have to be very careful not to suture the orbital septum, because if you suture the orbital septum, especially when you're closing the wound, you take a bite of the orbital septum, you can have lagophthalmos. Severe lagophthalmos will come, and you can have a lot of corneal problems. So you should learn to identify the orbital septum and make sure you don't include it in your closure bite. That's another important point which Madam has said. And I think she has beautifully covered the whole anatomy. Anatomy is the backbone of a surgeon. So you have to be very clear about anatomy, and especially the rule of one numbers are there, 12 millimeters, 24 millimeters, and 36 millimeters, like that. The anterior ethmoid, posterior ethmoid, and the optic canal. So you should know how where each structure actually enters the orbit, so that when you're operating, especially if you're doing a medial wall decompression, you should know to identify where the anterior ethmoidal vessels could be, where the posterior ethmoidal vessels could be, where to stop before the optic canal. So even today we go and brush up our anatomy before we operate, because it's a never-ending learning, because you here today, after 6 months, it's all again disappearing. So whenever you're trying to operate, you again go back, read up anatomy a little bit, and so that when you're operating, you know exactly what to look out for. And if your anatomical knowledge is very good, you'll automatically have very good surgical results, because only the lack of knowledge of the anatomy, you'll have a lot of complications. For example, if you don't know to avoid the vessels, you'll have a lot of bleeding and a lot of other issues. So a good surgeon always is very sure of the anatomy. Thereby he can avoid a lot of vascular problems and avoid bleeding and all that. So excellent talk, madam. Thank you so much. Thank you.
Dr. Kirti ma'am, any comments from your side?
I think everybody has covered everything. It was an excellent talk, very vast topic, a very volatile topic, but a very important topic, very well covered. And Dr. Dayakar and Dr. Senthil have already added all the extra points. So yeah, that's it. Nothing else from my side. Thank you.
Okay, thank you.
Thank you, Dr. Aparna. That was a wonderful talk. I have a question. You talked about the diameter of the optic nerve and how it changes along the course of the optic nerve, and how that's why we can do optic nerve fenestration. Could you break it down a little bit for us?
This is basically my theoretical knowledge. So what I have understood is that as the optic nerve exits the globe, it expands because all the three meninges, they are covering the optic nerve, which stop short of the intraocular part of the optic nerve. So if the ICP is raised, the subarachnoid space enlarges, and hence the diameter of the optic nerve just behind the globe enlarges. And at this point, if you are planning to do an optic nerve sheath fenestration surgery, so since there is more of distance between the dura and the optic nerve per se, so you are in a safe zone. You have some distance wherein you can put your knife and you can do the fenestration, is what I have understood. The experts, if they would like to shed some light on this.
Yeah, actually, that's a very good point, madam. Like you said, when we do optic nerve fenestration, one important point which you said was the ciliary ganglion actually is on the lateral side. It lies between the optic nerve and the lateral rectus. So usually our approach is to do it through the medial transconjunctival approach. So we go medially. We disinsert the medial rectus, and then you have direct intracorneal access and you reach the optic nerve just behind the globe. So we approach the globe medially, so that laterally, the ciliary ganglion side, you don't want to damage that. So the preferred approach is medial. That is one thing. And like you said, we keep the fenestration very close to the globe. We don't go very posteriorly because the central retinal artery enters the optic nerve at one particular point, maybe approximately 9 to 10 millimeters behind the globe. The central retinal artery enters. So you don't want to, go too posterior so that you don't want to damage that. So we do the fenestration just behind the globe, few millimeters just behind the globe is where we make our window, and we let out the CSF. So that again, anatomy is very important when you do that. So the medial
Another
approach is
point
better.
to add there is once you distance the medial rectus and retract the globe, the identifying factor will be your posterior ciliary vessels which are entering. So when you see that, right behind that is going to be your optic nerve, and so you make your window in between these vessels. So you don't want to damage any of the vessels. So that's where you make your window.
Thank you so much. Thank you so much, Aparna ma'am and Nathan sir and Kirti ma'am. That was very informative. And for a small surgery, actually, we've not seen fenestration probably or maybe assisted, but you can't actually see what's going on. So thank you so much for those anatomical tips here. And as we come to the conclusion of this session, I would really like to thank AIOS GuruSangam team for putting all of this together and getting oculoplasty this platform. And all of you all have prepared so well for the presentations that it is probably a very comprehensive guide for that any PG can easily access on YouTube now. I would like to thank Dr. Partha sir, Dr. Hunavar sir, Dr. Mathur sir, the AIOS dignitaries, panelists that we have today, Dr. Nathan sir, Dr. Seema Das ma'am, Dr. Dayakar sir, Dr. Kirti ma'am. And thank you for choosing us to educate on a Sunday morning. To all speakers, Dr. Shubha Zawar ma'am, Dr. Maurya sir, Dr. Sonam ma'am, Dr. Swati Shri ma'am, and Dr. Aparna Singhal ma'am. Thank you so much for making it so exciting and so comprehensive and systematic for us. I would also like to thank Sunil from Zadiotech, who has made this extremely smooth and flawless meeting for us. And all the live YouTube viewers, they've also put their comments in saying that it was a good session, and a few comments for each presentation we have there. Thank you so much. Thank you, Rolika, for putting all of this together. And lastly, to Shebin, who's been a wonderful moderator with us today. Thank you so much, everyone, for your time.